Good morning.
Good morning.
I am Vivian Darks, NAACP New Jersey State Conference Secretary and Health Chair. And I am very excited about being here this morning with this extremely knowledgeable panel and all of you who saw the importance of being here this morning to have a conversation about a critical issue impacting our community that needs to be addressed. I also want to acknowledge and thank the Southern Burlington County NAACP branch for partnering with us, along with Virtua for opening their doors today, providing this beautiful venue for this very important discussion. It is our hope that when you leave today, you will be armed with more information than when you arrived, and better able to advocate for yourselves and for others. You will note that we have gathered a very diverse panel to address maternal morbidity and mortality, as this is a subject that will require a broad approach from all angles to impact the current statistics across this country, specifically in New Jersey. This will require all of us in this room. Having said that, I do not want to delay the start of what I hope will be a very interactive conversation, and I will pass the mic over to the Southern Burlington County President, Ms. Crystal Charlie.
Good morning, everyone.
Good morning.
Good morning, everyone.
Good morning.
All right, that's how I like to start today. I don't drink coffee, so I need you guys to yell at me. So thank you for attending the State of the Black Mother, Giving Birth to Change, the cause, prevention, and legislation regarding Black maternal mortality in New Jersey. I would especially like to thank our New Jersey State Conference NAACP Secretary and Health Chair, Vivian Darks, and her committee for partnering with our branch, Southern Burlington County WIN Committee, to begin a very important dialogue that certainly will not end today. I must also thank Pam Gallus, AVP Patient Care Services, Maternal Child Health of Virtua Health Systems, for being so instrumental in the partnership between Virtua and our organization. We thank you for making the provisions to have us here today at your beautiful facility and working with us as we secured panelists and your demonstrated vested in today's topic. We certainly look forward to working together and again in the near future. I would like to thank our dynamic panelists who are with us today, none of whom thought it robbery to be with us on today. Our panelists represent the very best at what they do. They are well-credentialed and compassionate professionals and champions in the areas for which they represent. I'd like to thank Citizens Media for live streaming this event to get the word out for those who could not physically attend with us today. I'd like to give a shout out to the Southern Burlington County NAACP officers, members who are with us today. And thank you to our communications chair, Marcus Sibley, for getting the word out about today's event. Any members of the NAACP who are with us, who are not members of our branch, but represent various branches across the state, we appreciate you being here. Our state membership chair, Rosalind C. Wright in the back, thank you for coming out and helping us out today. And to our guests in the room, we thank you. I hope that you will leave here having learned something new and fired up, ready to do something about it. The total amount spent on healthcare in the USA is greater than in any other country in the world. Hospitalization related to pregnancy and childbirth is the highest hospitalization cost of any area of medicine. Despite this, women in the USA have a greater lifetime risk of dying of pregnancy-related complications than women in 40 other countries. According to Amnesty International, the likelihood of a woman dying in childbirth in the USA is 5 times greater than in Greece, 4 times greater than in Germany, and 3 times greater than in Spain. African American women are especially at high risk. They are nearly 4 times more likely to die of pregnancy-related complications than white women. In high-risk pregnancy, the disparities are even greater, with African American women being more likely, 5.6 times more likely to die than white women. New Jersey ranks 47th among the states in maternal mortality, with a rate of 37.3 deaths per 100,000 live births. Women of color account for nearly 60% of all pregnancy-related maternal deaths in the state. African American women are over 4 times more likely to lose their lives than their counterparts. In New Jersey, the preterm birth rate among Black women is 47% higher than the rate among all other women. This disparity must be reconciled. We are in critical condition. The U.S. government has a responsibility to ensure equal access to quality health care services for all without discrimination. However, gender, race, ethnicity, immigration status, indigenous status, or income level affect a woman's access to health care and the quality of the health care she receives. The intersection of multiple forms of discrimination can further adversely a woman's access to quality and adequate health care service in the United States. These disparities in access to maternal health care violate women's right to non-discrimination. According to the report from 9 maternal mortality reviews committees, which provides an evidence-based analysis of why preventable maternal deaths continue to take place in the U.S., an estimated 63% of pregnancy-related deaths in the U.S. were preventable. This is not only a public health issue. Moreover, preventable maternal mortality is a human rights issue. In closing, I would like to leave you with 2 quotes, and then I will turn the microphone over to Christine Baum, who will give our message from our county freeholder, Felicia Hobson, who was unable to be with us today. Mothers, the newborn, and children represent the well-being of a society and its potential for the future. Their health needs cannot be left unmet without harming the whole of society. Lee Jong-woo, former Director General of World Health Organization. The other quote, "Of all forms of inequality, injustice in healthcare is the most shocking and inhumane." Dr. Martin Luther King Jr. Let's make today transformative. Let us all leave here better informed and empowered to all be activists fighting for a better tomorrow. Our lives depend on it. Thank you.
Good morning. I'm Christine Baum. I'm the chair of the Women's Council here in Burlington County, and Felicia, our freeholder, Felicia Hobson, has asked me to deliver her address. There's a paragraph in here that Charlie has already hit on, but I'm going to go over it one more time because I think the numbers are a little staggering, and I need your brain to really wrap around those. So her statement says this: "Hello, and thank you all for being here for this very important event today. On behalf of the Freeholder Board and the Burlington County Women's Advisory Council, I extend my thanks to the South Jersey NAACP for organizing today's event. I would also like to recognize one of the Women Council's 2019 Outstanding Women Award winner, Crystal Charlie, for all of the community and advocacy work she does for women here in Burlington County." This is the part that is repeated, but it is worth repeating. New Jersey currently ranks 47th in maternal mortality. We have 50 states. We're 47th. With a rate of 37.3 deaths per 100,000 live births. Women of color account for nearly 60% of all pregnancy-related maternal deaths in the state. African American women are over 4 times more likely to lose their lives during childbirth. In New Jersey, the preterm birth rate among African American rate is 47% higher than the rate among all other women. These are alarming figures. In Burlington County, we are working to educate mothers through our Women, Infant, and Children program. This program provides nutritional counseling and supplemental foods to pregnant, postpartum, and nursing women and their children through age 5. A lactation consultant is also available for breastfeeding support and information. These services are available at the Burlington County Health Department in West Hampton, and we encourage you to reach out for additional information. On behalf of the Burlington County Board of Chosen Freeholders and the thousands of mothers in Burlington County, I sincerely thank all of you who are here today to spread awareness of this important issue. If we work together as a community, we can ensure both mother and infant will not only survive, but thrive. Thank you.
Now it's my pleasure to introduce our moderator and my friend, Dr. Judy Banks, who is a board-certified obstetrician and gynecologist. She is currently the Associate Residency Program Director for the Department of Obstetrics and Gynecology and Women's Health at Atlantic Health System, Morristown Medical Center. Dr. Banks is privileged to be tasked with helping to prepare the next generation of women's reproductive health specialists. Dr. Banks received her undergraduate degree from the College of St. Elizabeth. She is a graduate of Meharry Medical School and completed her specialty training at New Jersey College of Medicine and Dentistry. Dr. Banks, in addition to the professional obligations, has interest in global health and has worked with projects in Haiti for over 20 years. The recipient of many professional and community service awards, Dr. Banks is a life member of the NAACP and currently the health chair of the Morris County, New Jersey unit. Dr. Banks.
Thank you, Vivian. So I'm very excited and very happy to be here today. It's my privilege to be the moderator for this event. I just want to go over what the NAACP states as in its mission statement. The mission of the NAACP is to ensure equal political, educational, social, and economic rights for all persons and to eliminate race-based discrimination. This mission includes a focus on the right of African American and other people of color to have optimal health outcomes and to access timely, quality, affordable health care. African Americans continue to have the highest incidence, prevalence, and mortality rates from chronic diseases such as cardiovascular disease, diabetes, and obesity. And issues like HIV/AIDS continue to overwhelm the Black community more so than any other racial or ethnic group. The NAACP is committed to eliminating the racial and ethnic inequalities that exist within our healthcare system that undermine communities of color, their life opportunities, and their abilities to contribute fully to the common good. And the reason I decided to, to read that is, as it explains, one of the reasons for this forum today and why it's so appropriate for organizations like the NAACP to bring people together to talk about these problems in our community. I think that we are, I shouldn't say uniquely suited, but we are certainly suited to help be part of the solution and to disseminate information within the community. The organization is the oldest civil rights organization in the country, and is trusted in the African American community. And we think that we can, as I said, partner with other organizations, other healthcare systems, other people who are stakeholders in finding the solutions to this problem, and to really reach out and to do something that will help when we come back and look at the drop in the statistics of maternal mortality. I've been privileged to be an obstetrician for over 30 years. It's one of the great joys of my life to deliver babies. And I want young African American women and any woman from any demographic to be able to approach their pregnancy and maternity with joy, happiness, and anticipation. We do not want people to say, I don't want to get pregnant because I'm afraid I might die. So we really need to address these issues on many levels for many reasons. So, as I said, it's a pleasure and privilege to be here today. I'm going to step out here a little bit. I want to know who's in the audience because I think that will help us on the panel to know how to address the questions that you have, what you want to hear. So maybe we could just kind of go across real quickly, and people could just say their name, who they represent, and if any has an urgent matter that they feel that they would like to put out there, that they'd like to hear the panel address. So can we start? I guess let's start from the back. Okay. Okay. All right. Hi. All right. Next. Okay. All right. So are you just you're from the community? Can you just, you don't necessarily have to give your name, but can you just, I'm sorry, could you just tell us, why what you're here today, so you're here with your family, just want to get information, what made you come out today?
Well, I'm here with my family, my husband, and my 2 daughters. I know my husband wanted to support one of his high school friends who is working with the NAACP, so we wanted to come out and get some information.
My name is Tyrus Fowler, and I'm the political action chair of the Southern Burlington County chapter of the NAACP, and I'm here to get more information and support this event.
My name is Fatima Hayward, and I'm also a member of the NAACP Camden County East chapter, and I'm here just to get some more information.
Okay, so I think we're, okay, so next round.
I'm Dr. Ola Jackson. I'm an obstetrician here at Virtual Memorial Hospital, and I'm here to support causes dearly.
Tara Henderson, Director of Operations for Women's at Virtua, and I'm just glad that we are actually having this conversation. So this is
Mrs. Smith, Virtua, here to support.
I'm Kia Laura. I'm a student from the University of Michigan. This is just a topic that I want tonight from the sex classes, so I'm just a little learning.
My name is Salma Bayer, and I'm just here to get more information.
Did you go across? Or Mr. Rowe?
I'll be in this round.
Okay.
I'm Joe Morgan. I'm a doula in South Jersey. I'm part of the supervisory team of community doulas in South Jersey. I'm here to give support.
Okay, all right.
I'm Courtney Day, just a community member interested in learning more about it.
Yeah, don't say just. That's
My name is Jen Idler. I'm a labor and delivery nurse at Virtua, and I think it's important that we start the conversation.
Oh, fantastic.
I'm Mara Collins Drew. I'm the Healthcare Program Director at New Jersey Citizen Action and came to learn more. This is an issue we're very interested in and working on.
Tammy Balke, I'm the Healthcare Director of our grassroots group, largest one in New Jersey, Action Together New Jersey. Here for support, pulling together coalitions with anyone.
My name is Gina Sullivan. I'm an aide for Assemblywoman Conaway who represents this district. This is a topic that we frequently discuss in the office on. Here to get more information.
Chris Peace, Labor and Delivery at Virtual Voorhees, just wanted more information on this topic.
I'm Brenda Woodley. I'm Nurse Director of High Risk Community at Virtual Voorhees. I came to have more information.
Shayla Bivens here with Assemblywoman Shavonda E.
My name is Gwen Edwards. I'm a retired nurse from Rancocas, which is now Lords of Burlington County. And the numbers were bad when I was working. And when I read recently that the numbers were worse, and then saw this program coming on, I just said, hey, I've got to go. So I'm here prayerfully. We will get these numbers normal. And thank you.
My name is Kate McLaughlin. I'm a critical care nurse. I also represent 4,000 nurses in New Jersey as the founder of New Jersey Safe Ratios, which is looking to reduce overall mortality in New Jersey. We were absolutely disgusted by the numbers, but we've been doing a lot of surveying amongst our L&D nurses to look at what some of the root causes are. And we're out to educate our nurses at the bedside in regards to what we can all be doing. There is a significant lack of education when we surveyed our nurses, including myself as a critical care nurse, working in a level 1 trauma center in the medical ICU, and having never received actual training that I was supposed to get as a nurse. Had to take care of moms who were experiencing complications. So I became an advocate and started an organization 2 years ago, and we are fighting to protect all patients, but especially moms, because so many of these nurses are women.
My name is Joyce Winston. I'm a doula, certified holistic nutritionist and herbalist, and I just came to gather information. Hi, my name is Amanda Medina Forster. I'm the Executive Director for the Office of Minority and Multicultural Health at the Department of Health. And I'm very excited to be here.
Hi, I'm Susan Korngut, and I currently sit on City Council in Northfield, which is in Atlantic County, and I'm running for Atlantic County Executive, and so I'm learning about the issues. This is my top priority because Atlantic City has a significant problem and is one of the worst cities in our state. So I'm here to gather information so that I can hit the ground running when I win in November. All
I'm Eva Smith. I'm here to help Susan win in November.
Well, we have a fantastic group, and I understand that this is also a live stream. So we have people maybe at home who are just interested in the subject, who may not be as involved in healthcare as we see the majority of people in this room are. And it is a pleasure.
I'm sorry, Dara. I want to take a different hat. So I'm here because I received really top of the line care during my difficult pregnancy, and I don't want to miss the moment of saying thank you to Dr. Shaylin Shah, because he made sure that this little one was here despite having preeclampsia and having a very, very difficult time. So I already gave my speech as the president, but this became near and dear to my heart as a patient advocate, and I just wanted to make sure I had an opportunity to thank Dr. Shah.
I'm just really excited about your comments. You must be a mind reader, because one of the things that I had wanted to do today was to pick two people out of the audience and say, who had a good birth story? Okay? Because we want to start and we want to end on that. So you told us one, so somebody else got to say their good birth story till the end of the okay? So I'm going to introduce the members of the panel, and I believe down at the end we have Rashana Dickerson.
Ronsha.
I'm sorry.
That's fine. Just correct it down so we don't get it wrong.
Ronsha is the national organizer for Journey for Justice Alliance, a national alliance of grassroots community youth and parent organizations in about 25 cities. She understands that education is a human right. She organizes for community-driven alternatives. She is the co-founder of the Camden Parents Union, an organization in Camden, New Jersey, of parents, alumni, and business and community leaders who advocate for proper funding and equal resources. She's also the lead organizing parent of the Camden Students Union, working to save public schools. She is a labor coach and a birthing doula who serves women and families and having great experiences from prenatal health, and so the whole spectrum. I'm reading from this here, and so we're very excited that we have someone who is a doula who can speak to that, of the role and the importance of doulas in the birth process. Next to Ronsha is Dr. Shaylin Shah, who's been given a great shout out by Crystal. So Dr. Shah has a very impressive set of credentials. He is on the faculty of Thomas Jefferson University, the medical school, the City Kimmel Medical School here. He is the associate director, I believe, for the residency program also at Jefferson. Okay. All right. And so he's a fetal maternal medicine as a specialist. He has done extensive research. So we're very excited to hear what he has to say and the information he has to give out to us today. Next to him, we have Dr. Kim Bridges White, who is an obstetrician gynecologist, board certified obstetrician gynecologist, who I believe is in clinical practice in this area. And she again has a very impressive set of credentials. And so she's got some information too that we're going to, it's going to be very helpful for us today. Next to her is, I'm sorry. There we go. I'm sorry. Is our Assistant Commissioner of Family Health Services from the New Jersey Department of Health, Lisa Asari. Is that correct?
Okay.
Yeah. Ms. Asari was appointed Assistant Commissioner of the Division of Family Health and Services in New Jersey Department of Health in 2016. So she has worked in the Department of Health for 20 years in several different offices, including Health Statistics, Office of Minority and Cultural Health, and Office of the Deputy Commissioner. I'm not going to read through everything that she has done, but I know that this must be a very challenging season in which to be a leader within government circles. So we know that if you were chosen, that you were up to the task. So I'm very happy to have you here today. And we have Assemblywoman Shavonda E. Sumter. Ms. Sumter was elected to the New Jersey General Assembly in 2011, and she represents the 35th Legislative District. She has been extremely active, and I believe that you are the
Majority Conference leader.
And she has been very active in proposing legislation that currently has been enacted by the governor, which she's going to speak to us about. And but she has a long history of being an advocate for mothers and children, as you can see in the summary of the legislative initiatives that she has led. So we're going to start out, and we're going to start out with Dr. Shaw. Oh, I'm sorry, there's a video. Okay. Roll the tape.
Can you all see?
Hold on. Stop it.
Sorry, technical difficulty. 1 minute.
So when I'm preparing the video, I think that one of the things that I think probably struck all of us, okay, is that these statistics have been collected. It's only been known to people in healthcare and in public policy for a long time regarding maternal mortality and health disparities. But it is when the press picked this up, okay, in 2017, 2018, there were several major exposés and articles that were written in the New York Times, USA Today, that was picked up by all the major, news and cable outlets. Everybody, I'm sure, has seen those. And this is a visual, presentation about one of the stories that was very much in the press. There we go.
I hope you never have to read this letter. I cannot imagine you having to go through this yet again. And if you are, I am so truly sorry, Mommy. I hope you know how much I love you and how much you mean to me. I am sorry that I have left you. On the particular day that I am writing this, I have no idea how that may have occurred, but know that I would never choose to leave you. You will forever be my mommy, and I your baby girl. Shalom was my only daughter. She was loving, she was kind, she was generous. She was just always a curious child and loved to learn. She graduated from high school after skipping 2 grades. She went on to get her bachelor's at Hampton University. From there, she got a master's of science and then was accepted into a PhD program at Purdue University. She graduated with a dual PhD in both sociology and in gerontology, and she was the first student to do that at Purdue University. Both degrees were summa cum laude at all by the age of 25. She went on to public health because she had watched her brother, who was battling MS, so she decided she'd go and get a master's in public health from Johns Hopkins, and then went on to become a well-respected epidemiologist at the Center for Disease Control. Unfortunately, her brother passed away, but she still devoted the work that she did at the CDC to her brother. Shavonda was a very adventurous spirit, and we had traveled to over 20 countries in the last 5 years. She just loved life. When Shavonda found out that she was pregnant, she was just overjoyed. She had wanted to be a mother for so long. She went to every single OB appointment. She did everything her obstetrician required of her. She had fibroids removed probably a year before the pregnancy, and then she found out at the time that she had factor V Leiden. So she also had to take 2 painful shots every day to keep from clotting while she was carrying her baby. Well, based on her history, her medical team thought it was best that she have a planned C-section. She was prepared, she was ready, and she couldn't wait to meet the tiny human that she'd been sharing space with for 37 weeks. Shalon had tears in her eyes. She was so excited to see her daughter, and Shalon just held her. Within 4 or 5 days after getting home, she developed a lump on her side. She started having other symptoms as well, headaches. She wasn't voiding as she should have been. Her legs started to swell. She started to gain weight. She had headaches. And every time we'd go in to see a doctor, she was just dismissed with, "You just had a baby, give it time, it'll get better." And she says, "Mom, I don't feel right. There's something wrong." And I was just so concerned, but I didn't know what to do. During the last week of her life, Shalon went to the doctor 3 times for the same symptoms. On that last visit, she presented with blood pressure of 174 over 120. "Well, let me give you some blood pressure medicine, and you go home and come back in a couple of days if it hasn't gotten better. But don't worry, it should be fine. Just give it a little more time." Well, after we left the doctor's office, we went home and picked up her prescription, and we came home. And so we were sitting there talking a little bit more, and all of a sudden, she started to have this gargle sound that came out of her mouth, and her arm shot up, and she passed out. And I called 911. Probably 5 or 6 minutes later, the ambulance was there. When I got to the hospital, the emergency doctor told me that she was in pretty bad shape. I found out a couple of days later that she was brain dead because of the lack of oxygen. My cousin brought in a medical directive that I didn't even know Shalon had. And it said, "Mommy, I will fight hard, but if there is no hope, please let me go." And the next night, I happened to notice just one tear. It seemed like that came out of one eye. And I knew then what I had to do. We had her taken off life support. At 9:14, she was gone. I lost my vibrant, beautiful, intelligent best friend and daughter because she wasn't heard. I knew Shalon was a high-risk pregnancy because of her age, but I never for a moment thought that she was at risk of dying because she was a Black woman.
So this is very heartbreaking, a testimony to what happened, to her daughter. And so we can come back to that. This is one of some of the things that it brings out at another point. We're going to start our discussion today, so our panel with Dr. Shavonda Shah, who is our fetal maternal medicine, or I should say our maternal fetal medicine specialist. And if you could just give us an overview from his standpoint as a specialist of the problem of severe maternal morbidity, mortality, and of racial disparity.
Good morning, everybody.
Good morning.
I want to thank the organizers to allow me to be part of this panel. And Crystal, thank you for your kind words. That meant a lot to me. This is why we do what we do in the first place. But everybody understands that earlier this year, Boeing had two 737 MAX 8s crash. And it was after that that the government took action and Boeing took action. We have that equivalent, if not more, of two bigger planes of moms who die every year as a result of pregnancy or childbirth. And when you put it in that context, it's really upsetting and it's unacceptable. I know that we will not get to zero mortality, but that should be our goal. Because that story, if it doesn't bring a little tear to your face, you haven't been paying attention. A mother lost her daughter, but a child lost her mother. It's a huge impact. And what's upsetting is, in the United States, it's not a lack of resources. We have resources. We have to figure out how to better deploy those resources to cure and prevent and anticipate both morbidity and mortality in the pregnant mom. You know, it's upsetting that at a time when globally, and this is a good thing, globally mortality rates are decreasing. But at a time when globally mortality rates are decreasing, the United States is experiencing a slight increase. Now the reasons are complex and not easily answerable, but we have some tools already that we can do that with. So it's forums like these, it's thinking like this that's going to move the bar on maternal mortality. In this case alone, early recognition. We have at a time when my children see me try to text with my thumbs, they get upset because they feel that it's taking forever. When you can dictate to your phone and the text goes out, who would have imagined? I grew up in the time of Ataris, and anybody remember that?
Yes.
And now my cell phone has more computer power than that. At a time when we're one of the richest countries we're blessed to be one of the richest countries in the world, and we have incredible technology. We have to figure out how we empower our patients, our community, how we empower their care providers, and through legislation, insurance, etc., how we can reduce this. So I couldn't have said it better, all the statistics that were introduced, but it's upsetting.
Could you tell us, specifically, what diseases, what are people dying of? Why are they dying?
Well, traditionally, and this still plays a role, hemorrhage, bleeding is a big cause. Hypertensive disorders, which you heard on this film. Ironically, I do have to leave early today because I'm speaking on acute hypertension in pregnancy this afternoon. And I'm glad that I'm speaking on that, and I'm going to keep the story in my mind as I try to convey the messages that I do. Thromboembolism, clots. But in the United States, because we've done such a good job with cardiovascular disease, especially young girls that are born with heart conditions that are now, through surgery and medicine, able to survive and be healthy, they're now getting pregnant themselves. And so we have those challenges. So heart disease is really rising as an increasing cause of mortality and morbidity. And we're primarily focused on mortality, appropriately so, but for every death, there was near misses. And we need to keep focused on near misses also, because if we stay focused on near misses, that's how we're going to prevent death.
So we have a lot of healthcare, providers, in the audience, and I should ask you, what do you see some things now that your institution's doctor had mentioned that caused the death, the one that he singled out, was hypertension. So what is happening? What are some of the things that maybe people are not aware of that are happening in the management of hypertension and viewing of the pregnant woman in hypertension? Anybody want to speak to that?
Like I said, I've worked two large level 1 trauma centers in New Jersey. There's only a few, so that kind of narrows down these two of them. I also worked emergency room for years up in Newark for a very long time, Camden, New Brunswick. So it kind of give you an idea of the type of facilities I've worked in, well established. Like I said, there's a lack of education with the nurses, but also oftentimes with the providers and the residents. Critical care transport. So I get to travel around the hospitals throughout New Jersey, taking oftentimes moms from small community hospitals to other facilities. And there are times where there's still a lack of recognition in smaller community hospitals, but when there's a patient with preeclampsia, where if they're not being managed. And that's where we need to focus and really drill down on too. On the provider aspect is getting that education, because like I said, when emergency room nurses, and I have friends who are educators in northern New Jersey and Patterson who have told me, I have brought up an education packet to administration and they said no because we don't see enough. If 43% of the deaths are happening in New Jersey after the 43rd week postpartum, clearly there is something that we need to do. The person who spends the most time at the bedside is the nurse. So and thank you, Assemblywoman, for helping to get so much great legislation passed. But if we're not taking some of those funds for education in those hospitals at that bedside, then we're not going to stop another death of Akira. We're not going to stop another death of a Warren Bloomstein, because those are the ones that are being missed. And the people that are at the bedside are the nurses. The nurses must be educated, but we have to be empowered to be listened to. I have fought tooth and nail. I have reported a hospital. We have to do better.
We do have to do better, but there are a lot of things that are in motion, okay? People want to have this solved across the board. People do not want, nothing is more devastating in the life of communities than the loss of a young woman. And so, obstetricians and gynecologists, there, our large governing bodies, there are things that have been not acknowledged to us for long periods of time. And I know our panelists. I don't want to, Dr. Craig, could you speak to some of the new?
Yeah, I'm one of the my name is Kim White. I'm one of the obstetricians at Virtuo Voorhees, and I can tell you some of the great protocols that got introduced are really the hypertensive protocols. And I went to a conference just recently in February, and it seems that not across the board, a lot of the hospitals don't even have that policy instituted. So I commend Virtuo. They put that policy out. It's been out for a few years now, and that does help decrease some of the near misses. The nurses are educated on every floor about hypertension. They have algorithms that are laminated from triage all the way up to postpartum. There's certain documentations that have to be addressed, bedside visits that have to be performed, medications that should be initiated. Another one that they've initiated, they're starting to initiate now, is a postpartum sepsis score as well. And certain things have to be done depending on what lactate levels are. And that's very new as well. I learned that at the conference. That's in a lot of other majority of your high-risk hospitals as well. And I think that also helps avoiding the near miss. And just to address, to talk about maternal mortality in general versus maternal mortality in the Black mother, I just think it's interesting that, there are some studies that were performed that it doesn't even matter what the socioeconomic background of the Black mother is. So you have to dive a little bit deeper as to why that is. Because if we're taking out socioeconomic status, then what is it? Why is my complaint a little bit different than someone who is in the same exact situation who is not Black next to me? Why aren't my issues being addressed? I think when you start having protocols as such, the protocols do not discriminate where you are, what week you are, what your ethnicity is, and that's helpful if you're following guidelines. The key piece to that is also you have to have accountability for those guidelines that are instituted. You can have a guideline, but if your staff, your residents, your physicians, everyone up is not being held accountable for those guidelines and they're not reviewed, they don't really mean anything. So that's where you want to go. I appreciate your comment because this happens in every institution that I've ever trained and currently work. You're correct. There is a disconnect, I think, with most staff members, not just the ICU, the emergency room, but in all specialties. It used to be that I joked about this. Everyone that comes through residency that does a rotation in obstetrics and gynecology that's not interested in it, take vacation. They're not doing that. And I've often made statements, whether right or wrong, that I often find that sometimes pregnant women are actually discriminated against. It's part of your job in any field to know that. I wasn't interested in neurology at all. However, I recognize my pregnant patients may have neurological issues, so I have to pay attention during that rotation. And that should account for everyone in the medical field. You cannot be in an emergency room and not know that 140/90 may mean something to a pregnant woman, but maybe something different to the male who has 140/90. You're not an emergency room. You're not. So a lot of the protocols that need to be initiated or instituted in most of our facilities, the hospitals and the healthcare system has to start bringing these protocols to the emergency room, because there will be times that you will have eclampsia and a stroke. You may have chest pain and tachycardia. I've been called and I'm like, she is preeclampsia, please bring her over now. No Ativan, not for her nerves. She's not anxious. And there are just so many different levels. It is a complex situation, and I'm just very thankful that it just got addressed, and recognized, and that everyone's willing to try to take a stab at how do we get, these things rectified. Because I agree with you, to bring it back to normal, no, overshoot, 0, and then maybe we get it even less than normal. But there's some of the things I'd like to see just across the disciplines. I don't think the cardiologist should be different for the pregnant versus the non-pregnant. And then how do I know which hospital I'm going to that knows that? It should not be that way in New Jersey or any state.
Can I just address one thing? Because just a piece of information I'd just like to throw out there. So I think for the Alliance for Innovation in Medical Care, that they've had bundles out, which actually came out in around 2000. And they, along with the American College of Obstetricians and Gynecologists, that they are addressing the issues of hypertension, how to evaluate the patient. I'm sure that I know that many of you are aware of the MUSE protocols, okay, the early warning systems, okay, that are out. These tools are out there, and there are many places where they are being implemented, and they certainly are being looked at. And I know from the standpoint, I'm sure probably from state governmental agencies, they are more than aware and involved in asking for the implementation of these of these policies and procedures that are well known in the community. So I think maybe perhaps Lisa, could you just speak to that, because I know that same thing in terms of when we say people of color, and how do we, could you speak a little bit about quality initiatives and assessment of to get to equity, because I know these are things that would be of interest, and they directly address it, and this is going on in hospitals.
I absolutely can. So thank you for having me, and thank you everybody for taking time out on a beautiful Saturday to come and speak about this issue. I am local. I live in this area, so it was easier for me to get here than to get to Trenton, so I was happy to be here. But I'm a mother. I'm an assistant commissioner from 9 to 5 in the city of Trenton in the Department of Health, but any time beyond that, I am just a mother of 3 beautiful kids, 23, 19, and 10. God gave me a bonus and said, I have something for you. And I had them all in New Jersey. And I, like you, had very positive birth experiences. I have to tell you this, even being in this field, I did not know I was at risk. I did not know that there was any other option than coming home with your baby and being sleep deprived. I knew that, that's just what would happen. And all of my attention and all of my focus was on my children. It was never on me. And I had a doula who happens to be my mother. She sort of jumped in that role, and she was very, very focused on me and kept saying that this baby is fine, it's you I'm worried about. And I thought, let's focus on this baby. I'm fine. I say that to you because I come originally from West Africa, and her history had shown her that women don't always survive. Babies sometimes don't survive. And so she sort of had that mindset, and even though we're in America, a very industrialized place, she sort of said, no, I'm taking care of you. And so now, sort of looking back, I say, I get it. She knew something that I didn't know at the time, and something that unfortunately we're all here talking about today. But I, as I mentioned to you, have my own 3 kids, and 2 of them are girls, 23 and 10. So now as a mother, I'm still concerned about my baby, but now thinking about my babies in a different way, and understanding that my grandkids I'll be concerned about, but I'm really concerned about my daughters as well, and all of our daughters. I mean, this is just completely unacceptable. We have to put a full stop to this, as Doctor said. One is too many. One is simply too many. So, saying that about myself and sort of about what I think about this, we are doing things. We are being very proactive. We actually in New Jersey have had one of the longest standing maternal mortality review committees. And what is that? That is a group of people that meets every quarter to review the maternal associated deaths and the pregnancy related deaths, something that we would hope we wouldn't have to do. And what they do is basically open up files, look at medical records, and really come up with root causes. Did this woman die because she was in a car accident and it was not related to her pregnancy at all? Or was it something that was a complication that didn't have to be? And so they spend a lot of time doing that. We are sort of looked at as a leader in New Jersey in doing that work. But the point is to move from data to action. The data is all there. We sort of unfortunately see what it is, but what are we doing about it? And so I believe the moderator was asking, what are we doing about it? A lot of things, I think, from the clinical perspective, as well as from the patient advocacy and community perspective. It's a phenomenal time to be in New Jersey because I say the eyes of the nation are looking at us. Nowhere in this country is any state looking at this issue the way that we are. We have premier clinicians here in New Jersey who are engaged and willing to make a difference. We have our legislative partners who are pushing the agenda forward at all costs. And then those of us in the state are just redirecting our priorities and initiatives to make sure that indeed we are successful. I sort of mentioned to you I have 3 kids. The middle one is a boy. He's 19, he's a freshman in college, he's a track star. Or he thinks he's a track star. He's a track athlete. But he does, and I just say this analogy, say he does triple jump, and he's a jumper. I was at one of his meets a couple weeks ago, and he did well and placed, he medaled, he got, I think, 2nd place. But I say to him, the wind was behind you, right? What is wind? Wind is something that sort of propelled him forward. I feel in many ways the wind is behind us in New Jersey because we have a governor and a first lady who've taken this on as a personal mission. I was with Assemblywoman Sumter 2 weeks back when the governor actually signed into legislation 4 maternal health bills. We are making history in New Jersey, really making history. In terms of the clinical activities, we have something called the Perinatal Quality Collaborative that comes out of the New Jersey Hospital Association that has many of the AIM bundles. We are focused on hemorrhaging, we're focused on sort of the postpartum period, and unnecessary C-sections. We talk a lot about the maternal mortality, but the morbidity is really alarming. What are those near misses? Who's having C-sections that don't need to have C-sections? Unfortunately, really women that look like me are having them at a disproportionate rate. So we are working hand in glove with the Hospital Association and all of the hospitals to sign on to these bundles to just what you said, standardize sort of our protocols and practices, and using all of the levers that we have in the New Jersey Department of Health. What we're doing on the community side, I think, is really important because what I spend my time doing is working on an initiative called Healthy Women, Healthy Families, where we really work on things that support women in their sort of day-to-day lives. things like having a doula. We have one of our best doulas here on the panel with us, Rancha Dickerson.
Oh, so kind.
We do things like group prenatal care. But really, what are those things that equip women to get to your facilities and demand the care that they need? As you said, it's not about socioeconomic status. Vina Williams could buy us all, sell us, and buy us back. And she was not even listened to. So it tells you that it's not, just about folks who may not have the means or may not have the education. There's some implicit bias that goes on, where you walk in and people look at you and they sort of decide how they're going to interact with you. And unfortunately, sometimes there's negative consequences. So I have a whole lot to say, but I'll say that we are really committed to this work. We have $4.7 million that we have committed as a state to address these issues statewide, working in high need areas. There's a lot of work to do, but we are making progress to date. So I think it's my privilege to sit on this panel with such a diverse group of folks who will kind of all bring their perspectives, but I will speak some more. But we are doing the work around the clinical bundles with the Perinatal Quality Collaborative. And one of the bills that the governor also signed established a Maternal Quality Care Collaborative, MQCC. But this is similar to the work that was done in California that was able to reduce their C-sections. And it really talks about establishing a data center where we'll really move from data to action. We are as good as the data that we have, and without it, we really can't do any baseline work or really measure the impacts of many of the initiatives we'll talk about today.
Yeah, thank you. It's extremely helpful, and I know from reading that the state is extremely, proactive from the public health standpoint in addressing these, issues. And Assemblywoman Sumter, because I know that you have another engagement, could you please tell us, about the legislation that was recently signed in by the governor and your part, because I understand that you were the primary sponsors of some of these bills. So could you speak to that?
Thank you. And thank you for having me. Thank you all for taking this topic on. As a legislator, what we want to do is make laws that make sense to the 9 million people in the state of New Jersey. We want to deploy our financial resources from a $39 billion budget to make sure that we're impacting the quality of life for all of the citizens and future citizens of our state. To the Assistant Commissioner of Health, there is a substantial change that happened in the state of New Jersey when Governor Phil Murphy was elected. We actually ended up with commissioners who cared. Commissioner El Nahal was not afraid to call out racism in the healthcare system. We danced around it, which we danced around it for about an hour and a half. Yeah. If you have not noticed, yes. You finally said implicit bias shortly. And for us as healthcare professionals, we like to believe that everyone bleeds the same blood and that we're treating the symptom, we're treating based on these bundles that were mentioned, and we're not looking at the person when we need to look at the person and we need to hear what the person is stating to us. Also, as a healthcare professional, we like to believe that we're trained in cultural diversity and sensitivity. Now, we're in virtual, beautiful facility. You all have to do an annual cultural sensitivity, cultural awareness training, correct? Every person who works in the healthcare system has to do it. Instead of it being a check, right, we really need to make sure that it is threaded, ingrained, and there's a systemic change in our system. I work in behavioral health, so I know all about biases, 20 years in the business. So I'm not scared of that space, but when we're practicing and we talk about emergency room, let's not forget that we're on time constraints. They're moving a patient through, there's workflows, right? You're trying to get the patient out. And we're also trying to deal with a very complex patient, not only from a ethnicity standpoint, forget the socioeconomic status as we heard in this video and as we see in this room, but we're also talking about a patient who may have a substance abuse history, who may have mental illness, who may have some other environmental health issues that the professional has no knowledge of. So when we came up with this package of bills, we spent about a year starting with the Legislative Black Caucus, and I need to share that, hearing from women across the state. And we did 3 hearings across the state from every spectrum: healthcare professionals, public health workers. I'm glad you're here if you're running, especially for county office, because those precious dollars need to be deployed into a system that will work to impact change. We have to get to 0. It's not an option. If we start out saying we can't get to 0, then we're not going to get to 0. New Jersey is being watched. The wind is beneath us when you have a governor who's willing to put money into the system. When you have an assistant commissioner out on a Saturday willing to talk about this issue. When you have the NAACP promoting this very complex issue. And for the men who are in the room, when the woman is not being heard, we need you to stand up and say she needs to be heard. So this package of bills we are proud of. It includes supports for doulas paid for by Medicaid.
Yes.
We also, it's a pot of money that we can control. It's not that we're not looking at the commercial insurances, but it's a pot of money that we have control over that we can put some constraints around. We also looked at protocols because we realized as we talked throughout the state that there were no set protocols that any hospital was using consistently. Every practitioner had his own set of practices that it used and partnered with the hospital association to say, okay, what's best practices? And then we put penalties with the early deliveries. So what you usually hear is, my doctor's gonna be away on this date. This doctor has been with me through the journey of my pregnancy. I have 2 children, 19 and 20. The 20-year-old just graduated college last Saturday, so real thankful there. Thank you. Thank you. Cum laude, I have to add that as well. And she did it in 3 years, okay. All right. But we had to put some constraints around saying, okay, it's not safe. You want to plan this delivery, you want an early delivery because you want that practitioner there, but it may not be safe for the mom, so put some penalties around it so there's no incentive to deliver early. And it's unfortunate that we had to go there, but it's important that we go there. I work in a hospital. Our hospital now is tracking the reduction in C-sections, where I've been in the hospital for over 20 years, 3 different hospitals, and that data I never received as a quality measure to say, okay, how many C-sections have we not delivered? That's a great thing. It's a change in practice for the clinicians in the room, but it will impact the safety and the health and the wellness of the mom and the baby. We're also working on pilots. We want more doulas. We want training for those doulas. We want doulas who look like the moms that they're serving, who are not afraid to go into the communities. We also realized that transportation was a major issue. I drove 2 hours to get here. Beautiful facility, right? Was happy when I made it here. But for a mom who's in Trenton, you cannot deliver a baby. In the city of Trenton. We did not realize that as legislators. If you want care, you have to drive to the next town. How are you going to get there for your follow-up visits? Right, you're shaking your head. Those are realities that we did not know existed as a barrier. So how can we make sure that providers are practicing, that compensation is there to cover the care that needs to be delivered for all, and we still have a ways to go, and that we're incentivizing our practitioners to work and support these moms who are delivering life. The other piece that we realized, after 60 days, if you had Medicaid, it was stopped. Does the health care of the baby not exist post 60 days of delivery? Yes, no? So we put a 365-day calendar period around making sure mom had benefits to take care of that child post-delivery, and follow-ups are there. So it's not all of the answers, but I think it's definitely a step in the right direction. The other major piece that's internal, operational, that elections have consequences, is we have 3 divisions that are now working together. Department of Health, Department of Human Services, Department of Children and Family Services. And for those three entities to communicate, to cover the lifespan, prenatal care, to birth, to living past that first year, it's important that it's coordinated, because if mom has another child at home that she has to worry about, and then has a newborn, and then possibly has to work somewhere in that space as well, all of those services matter, and we weren't talking. So breaking up those silos so that we're communicating and that the resources are partnered around the wellness of mom, baby, and family. So we're busy. Thank you.
Thank you. And Dr. Shaw, before we get to our doula, because we want to really delve into why this was considered as a legislative initiative and has been put in place, could you just speak to, because the one thing that I want to emphasize, okay, just in patients to know, can you speak to when, okay, in pregnancy and the postpartum, when do people get sick and die? Because I think that the public, there was a misconception, they're like, oh, you had the baby, I took you to all your visits, I got to get back to my job, and I know you got a headache, or I know you don't feel good. Can you speak to the significance of the different times during the first year postpartum, okay, that people actually do die, and because that has driven also some of these initiatives?
Thank you for that question, Judy. I was thinking to my education as you were speaking, and learned a lot about anatomy, physiology, biochemistry, but learned nothing about bias. Now, I trained 5 million years ago, and I'm hoping that it's different now, but I really think, and I'm going to circle back to your question, but I really think that a mom's health has to do with her provider's health also. And by provider's health, I mean their education. So we all, whether we try to lessen them or not, have subconscious biases from our experiences, from our upbringing. And if we don't acknowledge those biases, we're not going to be able to standardize our care across the spectrum. And I believe that training really starts, in my case, in physician's case, in medical school. And I'd like to see, we have an opportunity in Jersey, because Jersey has a medical school, to, if it's not already there, introduce bias awareness and bias training. There are modules out there that are quite effective, quite eye-opening. Having said that, I think once the care provider is able to acknowledge their own biases, really a mom's risk starts pre-pregnancy. I'm amazed at how often I don't see a potentially sick mom until they're pregnant or until they're about due. I have a particular interest in heart disease and pregnancy, for example. In fact, at Virtua, I initiated and we run a multidisciplinary cardiac clinic for pregnant moms and non-pregnant moms. Non-pregnant moms want to be. Despite that, sometimes I won't be aware of that patient. My team won't be aware of that patient until they're 36 weeks. Really, that patient's care should have started pre-pregnancy, where we could optimize her health, her diabetes, her hypertension, etc. Then it continues throughout pregnancy. It's a bilateral relationship. It's not one way. I'm not sitting there dictating to my patients. It's a conversation. They're adults. They're able to make their own decisions, but I'm incorporating them. And they have to help me take care of them, because they have to help me understand their barriers. So often we'll say, oh, well, she's non-compliant, she's not engaged, she's not interested in healthcare. And sometimes they don't have the means to get to all their prenatal visits. It's not that she's not engaged and she doesn't care about healthcare. So how do we practice medicine in a way that allows us to individualize that care for those who have less resources, those who have more resources, those who have less education, those who have more education? We see the most morbid and mortality events occur in the 24 hours preceding delivery and in the 24 hours after delivery. But there's plenty of things that happen way into the postpartum period, long after the, what did you say the cutoff was for?
60 days.
Yes, long after that. And oftentimes, when they leave the hospital, we don't even see them until their postpartum visit, and they're very vulnerable during that time. Think about it as human beings, what do? All the attention is on the pregnant mom, and then it shifts immediately to that baby. Right. And by the way, what happened to that pregnant mom, for all those months? So really, I would argue that the risk for the mom and the care of the mom began in medical school or whatever school that you attended, and continues pre-pregnancy for that person and post-pregnancy.
Yeah, and so I just want to see that emphasized because people are vulnerable in the postpartum period. A lot of people are not aware of it. The patient is not aware of it, and nor are their family members, or possibly, as someone had brought up, ancillary medical personnel that they may come in contact to. Dr. Briggs, I know you're in clinical practice. Can you just make a couple of comments, and then we want to get to Shonda's perspective as a doula?
Yeah, I mean, I agree with everything. I was just thinking about my practice in general, and maybe, just looking at some of the data, a lot of the deaths occurred even up to 42 days after birth, and a lot of the protocols we have now, short of surgery, we'll see the patient back in 6 weeks. And maybe that should be adjusted. Maybe you should see a patient back in 2 weeks, and then 4 weeks after. That might be something to consider. The other issue really is, I definitely have already looked into doula programming out into all different types of communities, and not just for the patient, because for a lot of Black families, you're relying on the family. So I know my mother gave me advice. I was like, thank you very much. And called my brother, and I'm like, I'm not even sure why we're alive. I'm not even sure. And all I got was Oprah said, and whatever they train you new doctors on, and I was just like, okay, thank you. And I'll hear that. Or, even with moms with mental health issues, a lot of Black families rely on churches, pray on it. You have to be tougher than that, have a thicker skin. I can't tell you how many times I've been told that. So there are a lot of, I think, educational benefits for doulas, even for not just the patient, but get the surrounding family engaged too, and partners. There's a lot of good things I think that can come of that can keep an eye even on the postpartum phase, if there were some resources for that, even for patients that aren't on Medicaid, any socioeconomic status, you could devise all types of programs. I think that would be helpful. But yeah, I hear you with the C-section risk. We definitely join that. We're still actively engaged in reducing the rate of that. That does help. But as far as the causes for the Black deaths, the cardiovascular risk, the preeclampsia and the eclampsia, I think there has to be a lot more work with recognizing these symptoms, even for the offices that field the phone calls after you deliver. There should be more resources and more awareness even for your office staff that say, put your feet up for a minute. People always swell a little bit afterwards. That does happen. As far as hospital bias and racism, yes, it exists. I can tell you that. It existed with, my own experience with sending my husband and my son to the hospital. It happens. And I agree that there has to be more education for that. Not just the computer programs that, you're right. You check it off, and some of the programs, they're just ridiculous. Yes. I mean, they're ridiculous. I mean, everybody laughs at them when you're doing them. Right. But there has to be more accountability, more listening to the patients. I did shrug, my hair went up on my back a little bit when you also mentioned having the partner or the husband speak up for the patients. We have to be careful of that at institutions. That often is seen as aggression. I've had security called on partners for this. asking too many questions, leaning over me, you know. You have to, you do. I mean, it sounds ridiculous. No, no. Right, so it sounds ridiculous, but it happens. You know, if I would never call security, if I had to call security for every time I felt intimidated in a room where I work, that would be overwhelming. So I think there are a lot of little things that need to be addressed, and everybody has them. I have my own biases. Be aware of them. You know, talk about different cultural experiences. Talk about different religions as well. That's helpful. There are certain religions that you can't eat from sunup to sundown. And that should not be poo-pooed. There are plenty of diets and recommendations to hold those pregnant moms during the day. There are a lot of different cultures where the whole family comes in postpartum and are engaged, and we only have so many visitors. And that should be for protection of everyone on the unit, but that should be recognized as well. I think if there was a little more education in everybody's different ethnicity, different religious beliefs, I think we could make some progress or take a stab at this problem.
So those are, just really all, really good points. Just to extrapolate from that just a little bit, I'm just curious, Lisa, I know the state has mandatory cultural competency, okay? Do they have mandatory bias?
They do not.
Is that something?
It's something that we are. It's on the horizon. It's happening. Absolutely. Absolutely. I think the thing with some of those mandatory situations is the enforcement, right? I mean, who is really tracking? You know, who is really keeping a close watch on that? And if a physician doesn't do that, what are the consequences? And so I think that we have more work to do there, but we're certainly moving in the implicit bias direction as opposed to just the cultural competency.
Rashonda, could you speak to the role of the doula and how this has come to prominence in this time?
Oh, wow. So, yeah, I've been just sitting here kind of just absorbing a lot has been said, and I'm number one, just first of all, my name is Ronsha. Ronsha Jefferson. I'm a mother first before I get into so many hats that we all wear. I'm a mother of 6 children. And it does get people like, oh wow, feeling like, how did you do it? Yeah, I had the experience of going to hospitals and, birthing 6 children vaginally and naturally. And my first 4, my birthing experience, I birthed in New Jersey at Cooper Hospital. And my first 4, I was a young mom, young wife, didn't have a clue about what was going to happen to me and my body, my transition. I had the kind of moms that were, telling me some things that were like, huh, mom? Those kind of things. So, but I did, in my family, we had that cultural aesthetic where grandma knew some major things and mom knew some major things and auntie knew some major things, and we used that to kind of get through. However, sometimes it's just not enough.
Yes.
So my experience for my first 4 was natural childbirth, breastfed for over a year and a half. And that was my choice. That was my decision I made. At that time, I was a stay-at-home mom. I stayed home with my children. I was able to be in that space. And I can't say that every Black woman has that experience, or every woman has that experience. But I was able to be in my utopia of just like, my children and things like that. But there were some things that were missing. My last 2 pregnancies, my water broke early. And I was petrified. 24 weeks. Didn't know what happened. Had no clue. No education on this at all. Nothing. When the hospital was bed rested for over a month and a half, and my 5th child I had to be rushed to emergency C-section. Had no clue. Before natural birth, you think you're a champion in this. You're doing it well. And I had to go through that process with her, and I didn't know if I was going to make it or she was going to make it. And it was a transition for me. And we got through that process, and then by the time I had my 6th child, I was petrified to be pregnant again because I wasn't sure what was going to happen. Now I'm saying all this to say, in this whole process, I did not have a doula. I didn't, because we didn't know what it was. Right. Family played the role of doula. Mm-hmm. We do, as African American women and women, we know that we have doulas in our lives. But I didn't have a doula like the way that Lisa said I was a doula. I'm like, where is she at? I'm like, trying to figure out where she is. And I want to say that I represent all the doulas in the room. Doulas are just amazing people. But to get into the texture of this conversation, it is a lot to unpack. All of my children are healthy. I thank God for that. My premature baby would not. I mean, this firecracker. Whew. Yeah. So, but the experience of having, I can say that the Cooper staff, and I'll say this publicly, the Cooper team at the time did the best they could of what they knew. They were very good at doing what they could do in the maternal and infant unit that they had there that cared for me and my children, my child at that time, and my family. But had I known about the things I know now, maybe I would have raised some questions. You know what I mean? I would have raised questions at the time. There were some things that were kind of off to me. But I didn't know, and I felt like my voice wasn't valued because I was just going through the motions of, I just want a healthy baby, and I just want to go back home to my children and my family. In this process, my husband, and again, speaking about men involved in the process, his voice couldn't be too loud or be too soft because there is that feeling of aggression or being aggressive. So that's a little bit of story about myself. My children now, older, my oldest is 21, he's an African percussionist, traveling around the country. My daughter, she's at Cornell University, and my other 4 are still in public school. So my background now is, yeah, I'm an active stay-at-home mom, but not really so much more. Now I'm really out in the community doing the work, and my work really based around from like education from the cradle up until you graduate high school and into higher education. The role of the doula that happened with us is a true story. When I became a doula and became certified moving forward, my trainer is inside the room, Jody Green. She's one of the doulas who are pushing past the implicit bias of it only can be a separation of white women doing this and black women can come along if they want to. Jody was intentionally putting black women inside of her cohort and training black women and saying, listen, we all have to do this work. It's all of us having to work and figure out how we can help build in partnership. So I'm from Camden, New Jersey, and in my city, there were only 2 women who were doulas, and I was one of them. The other one is right now my assistant supervisor for this program. We'll talk about that in a second. So Jody was a part of the process of us meeting people like Lisa and the Department of Health and being able to find a space for a grant where they were screaming, where are the freaking doulas at? Where are the doulas? Where are the doulas? That was at the end of the day, it was like, where are the doulas? Right. So Jody became, from her vast experience in being a doula for over 20 plus years, she was in the space where she was a white woman helping writing and being partnered within this grant process. And the request was for it to be led by African American women, African American doulas, because the issue was the maternal and mortality rate of black women. I don't want to just keep saying women of color. I cannot do that. I have to say black women in the space. Black women were suffering in hospitals. The 4 cities, especially Newark, Trenton, Camden, and Atlantic City. We focused on those 4 areas. So when I was brought to the table, it was Jody, a white woman, who was like, listen, we're not gonna play this game. I know a doula and she can do it, and I'm gonna step back. And she said, Ransha, we prayed over this, we cried over it, we're on the phone about it, it's happening, it's your time, get in front of this and deal with it the way it's supposed to. So, and that right there, I'm putting them as just a pin that for every white person in this room, you have to step back and allow the people who are supposed to be impacted by it be in front of it. All right, all right. So, with that being said, just trying to tell this true love story. Jody and I, it was battle time. We were at the table. The Department of Health was there. There was a grant. There was money. And when that comes out, it comes with a lot of different criteria and recommendations of what needs to be done. And I applaud New Jersey. I have to say, this is the first time I really feel good about being in New Jersey. All right. I gotta say that publicly. Jersey. All right, Jersey tomatoes still. Okay. With that being said, I felt good about it because in this partnership, we partnered with SNJPC, Southern New Jersey Perinatal Cooperative, and this group of women, which is really a white-led base, they were also checking their privilege too and saying we can't do this on our own. Though we have a lot of programs that we offer out to women, black women and women of color, we can't do this on our own. So our program under Healthy Women, Healthy Families was for them to find a community-driven program to lead the doula work that they're asking for, and that's where we came in at. So I was already doing community programs under NIMBA, nurturing infant mothers, babies, and families. and we were working and teaching, just having just community-driven conversations about Black birth, Black women, the state of the Black womb, things like that. We were just doing it on our own because we said if we want to see change, we have to be the change. That was just happening in Canada specifically. Then when we got part of the grant writing process, it was layers to it. And I have to really take a moment to really teach about that because I think people think it just kind of happened. There's layers to this. So we ended up partnering with SNJPC, and I want to make it very clear we had never worked with them before. So now you got a new partner coming that's community, very grassroots. One day you might see me out in front of a sea of 1,000 people talking about education justice. And really resisting because that's a big fight that we're on right now, or talking about the Economic Development Authority, how they're taking money from the residents of Camden. You may see me there. All that to me is dual work. I'm just serving, right? Yeah. All that's dual work, right? So I'm just serving in this situation. So we were able to partner with them and learn about the amenities of what was going on with SNJPC. Then it was turned to, we need you all, community organizers, the doula group, NIMBA, to now organize women to be a part of this program. It didn't require a lot. We were already known in the community. We went on social media. We posted up just one flyer and said we were interested in now training Black and brown women to become doulas. The flyer went viral. It went viral, went crazy, just off of our basis, just off of the women that we knew in the community. So I'm trying to fast forward a little bit faster. We ended up getting over hundreds of women that were interested, ended up doing 4 trainings four information sessions to get women to come in and kind of hear what the criteria was. The criteria was very simple. You had to be an African-American woman or identify as an African-American woman. You had to live in Camden or Atlantic City. And you had to have transportation. You had to be willing to be a part of a week-long intensive training under Uzazi Village. Now, Uzazi Village is special as an insert in this conversation because Uzazi Village is the training module that was used by the Department of Health to give training to African American women to do this doula program. And people can say, we could have used CAP or we could have used other folks. We handpicked Uzazi because they were an African American model that were teaching ancestral ways to train Black women to be able to deal with Black women in these situations. Does that make sense? Yes. I was trained by CAPA originally. CAPA did not have a culturally biased type of chapter. It was just like overall general doula. But now with Uzazi and the expertise of Hakima Payne from Kansas City, she was able to create a module that women of color can see themselves, especially Black women, and be able to use this to be able to get into professional places and train, and be able to also become a trainer and train more Black women. So we trained for 1 week Uzazi. We were able to get our numbers were 10 doulas. Right, Jody? We pushed about 12. We pushed the envelope a little bit like, you guys can give us a couple more dollars. We'll do 12. And that was a small number, but we were able to get 12 women, 9 from Camden and 3 from Atlantic City to become trained in the process. So on that training, us working with the Department of Health, this has never happened before. This is brand new. This is a new pilot program that has never, it's like I'm living in the moment right now. Yes. Sitting right here, still living in the moment. There was no conversation about where Black doulas are, where Black birth workers are, what is happening in South Jersey. It was not happening. We were able to get these 9 women, 12 women to be trained, and they are now able to do a few things. Number 1, certification training. They become already their own boss. So they can become take personal clients with this certification, so now they can do their own type of business through the doula program by being a doula. Number 1. Number 2 is in the program itself. We developed a new term, a new kind of like entity under SNJPC called Community Doulas of South Jersey. So we created. So NIMBA was first. That's my baby, right? And then we birthed Community Doulas of South Jersey to give everyone an idea of Black and brown doulas working together in the South Jersey area. These women are now able to do 3 prenatal visits, to some of your points, a birth, labor and delivery, and also 2 postpartum visits. And with that 5 in mind, they are paid per visit. They're paid to do the service they're doing through the Department of Health grant. The grant's paying these 12 women to do the work in Atlantic City and in Camden, New Jersey. They are able to go into homes, meet women, going through a process of referral systems. Also, we do a lot of community recruiting ourselves. But the bigger part of this program that I want to really talk about, that I think that no one really sees the beauty of it, is that Black women are now sitting at tables with chairmen of obstetrics. We are sitting at ground rounds talking about what it is to be a doula. We are sitting with nurse providers, women care centers, and we are partnering with these people. We are sitting with the First Lady and the Governor having a powwow about how important being a doula is. Yes. We're talking to Assemblywomen, we're talking to Commissioners of Health, and having these conversations. 3 years ago, wasn't happening. There was no voice for Black women and women who are doulas to be at these tables. Legislation has been changed based on our work, and I have to say that very clear today. We have testified, we have fought, we have done everything we can possibly do. When I say fight, in the battle of hear our cry, we hear our thunder at the same time. That was the spirit of what we were doing for doulas. So the benefits of having a doula. I just wanted to give you this part, and I'm gonna sum it up here because I know people. Sometimes I can really get passionate. There's 10 states that have the highest maternal death rates. I want you to just hear it and then start thinking about what states are pretty much Black. Louisiana, Georgia, Indiana, Arkansas, New Jersey, Missouri, Texas, DC, South Carolina, and Tennessee. And in those top cities, about eight of them are Black cities. Black states. They're states. Yeah. A lot of them have a lot of Black cities inside those states. So imagine how impactful it is if this program we have here in New Jersey is to become a pilot in every one of those states across the country, right? Where we are now bringing community doulas like ourselves. We are not clinical. We are women who go in and work with families, not only the mother and the child, but families too, because the experience is new. A lot of women don't even think they can afford a doula. Right. Most times we go into these practices and go into these homes and deal with clients and things like that. They ask, I can't afford you. Thank God for the Department of Health for bringing this grant. The question is, how do we sustain it post this? Well, Medicaid said they'll pay us. Isn't that something? Yeah. Now Medicaid is covering doula services. Right. At one point it wasn't happening, but because of the fight of legislators and commissioners who are fighting hard for this, we are able to cover the ground, right? And I'm screaming this from the mountaintop because this is a time that African American women are shining because we did not feel valued. I want to say that to everyone inside the space. I speak for thousands and thousands of Black women who did not feel valued in hospital settings. There is an implicit bias. There is a high level of injustice and racism and inequity in birth in hospitals. Women are dying at a rapid rate. Babies are dying at a rapid rate. Their women are going home or not coming in because they don't feel valued. Yeah. They feel so as soon as they open their mouth, I'm going to be judged based on my social economic status. Just because I might be a baby mom of five children with 5 different daddies does not mean I'm still not a woman. Right. It does not mean that. Right. And then we also have to check ourselves on our privilege because, as the governor said, it doesn't matter how the baby got here. First lady said, I don't say it verbatim because I don't want to quote Mrs. Murphy, but she's amazing. It doesn't matter how mama got here. It's just that I would like to see every mother have the same experience that I had. And that's important. Right? How is it that white women can have such great experiences, and I'm not gonna say all, because some have had bad, but Black women have had far worse experiences than white women. And then we can go deeper down the line, and we do have to call race inside the space, because Black women are suffering the most. The numbers don't lie. The numbers don't lie. In Atlantic City alone, the mortality and infant and maternal mortality rate is 3 times higher for Black women than it is for white women. Women are suffering amazingly. Camden alone, same exact thing. If you would just see how many young girls are pushed to have cesareans based on the lack thereof of knowledge, the lack thereof of education, the lack thereof of family support, and the lack thereof of anyone caring about what they would like, what they need in those facilities, you would be surprised.
They don't make them an option.
It's so many things we unpack in this space that I just think we don't have enough panel time for that. But this is what we're here for, right? This is what we show up for. I represent women all over the state of New Jersey, all over the United States of America that are using their voice to stand strong for women's wombs, especially Black women's wombs. So I want to leave you with this. I just want to tell you a couple of things before we move on to the rest of the panel. Is that we are currently, this is what we're looking for. We want to partner with you all. The community doulas in South Jersey, we want to partner with everyone. We're looking to do partnerships with hospitals, partnerships with operation managers, partnerships with local nurses, community outreach, OBGYN committee staffs, women care groups, and also transportation. That issue that was raised in this space is so important. Black women are not able to get from point A to point B and lug 3 or 4 children across the town to get to their visits. We want to encourage women that having a doula inside this with them is not because you don't know what you're doing, it's because you know exactly what you're doing. Right. And you need a woman or someone to be in that space with you to also help you see that you can get across this hurdle. Yeah. Women at points, and I just want to close with this, having a doula is just having a servant inside that room. And servant not in the spirit of someone who do just what you say, or someone who's humble enough to love you through the process. Because everything that goes on inside that birth room is not pretty. Right. As Jody always says, birth is very juicy. It's very juicy. I love when she says that. Birth is very juicy, and it can be extremely crazy at times. It goes through emotional roller coasters. But having a doula in that room just to say, this is normal. You're doing okay. We got you. What do you need? I'm here to help you. Having a woman have a birth plan. A Black woman said to us at one setting, I never knew I could have a birth plan. Right. These are things that we got to check on ourselves. Black women don't even know because we've been told no, or we don't feel valued that these things are important to have. I'm not saying all Black women have that experience, but I'm speaking for all of my sisters who struggle and don't know that they can have, or don't know after the postpartum process that someone still should be there with you, walking you through the process, holding your hand. So I'm saying all to say is that yes, the doulas are important. We are not to combat with any of the staff that are in the hospital. We are friends. We are friends of them. We don't want that to be the energy. Nurses, I'm being honest, I'm gonna put it on the table right now. Our experiences in some hospitals in New Jersey is a little weird because we're getting the spirit of we're coming in to take over, and we're not. We're coming here to check on mom, baby, and making sure that all is well. Because there are some things that are going on with cord clamping. I'm gonna put it out there. Some things going on with women being able to have that skin-to-skin time after birth. These are some things we've got to start raising these bars on and saying why is it when a Black woman comes with a plan, there's always another story of we can't do that right now, or we don't know we're able to do that, we don't know we can keep your placenta. These are things we got to check on because they're happening every day in the hospitals. And I might be going a little far off. I want to dig too deep in the weeds. I'm gonna come up. So with that being said, I just want to say to all of you, this space and this panel, thank you, Crystal, for making this important, because the state of Black women right now in New Jersey, though we are passing legislation, though we are passing law, when it hits the ground, where us, the organizers, or the organizers or the doulas are, a doula head on, we are seeing some things that are not connecting to the value of Black women. All we would like to see is that the way that we all see baby bags and pacifiers are used. Oh, she's so beautiful. Do you have her little, do you have this, do you have that? Same thing should be asking Black women, where's your doula? It should be the same exact thing. The same way we say, do you have this, do you have that, all the things that we line up, that's what it is. We should also be asking, who's your doula? Make that become a household name. Who is your doula? We have plenty of women who are able to serve and do this work, and women of color, especially Black women, need the support. And I would just ask all of us inside this space to figure out, go deeper inside yourself, dig deeper down to your roots and stretch your edges to find out how can you partner with other Black organizations to make sure that the work that you do in these institutions is connecting to the women who need the most. All right. Amen. You want to drink the coffee?
I want to drink whatever coffee you're drinking.
I just flew out from Atlanta, so I just got to stop on that high off the plane, I think. Yeah.
Yeah, that was really wonderful. And I just want to ask one, and it was so intense, okay, that I got to ask one question to the audience, and I don't know if people would like to have a short break. Are there any nurses here who have worked with doulas, and what has their experience been? Good question.
I have to say, I work with Jody quite a bit, and Jody is phenomenal. She is probably the best doula we've ever had. But I will say, kudos to you guys for your training. I recently had a patient who had one of your graduates in your program, and she was phenomenal. She was young. I don't remember much about the patient except that she was young. And I didn't want her in the bed when she was early in her labor process, but I couldn't convince her to get out of bed. She was, no, I'm fine. No thanks, I'm fine. Okay, so, whatever, I'm busy, I'm a nurse. I'm trying to stay at the bedside all the time. But when I came back in the room, she was out of the bed, on a birthing ball, moving around, and her doula visited her. Her doula got her out of the bed. So I was so grateful that that girl had shown up. So after a little while, we conversed, and I realized she was a graduate from your program. So you guys are doing great work. Thank you. And one more question. Is there any grant money for women with private insurance to get a doula? Because it will be cost prohibitive for a lot of women who have private insurance.
Yeah. So, is anybody want to speak to that? That's in my wheelhouse, but I always defer to the people who are dealing with it more often than me. Anybody want to speak?
So I'll answer that. I think that we began these pilots just for that reason, as pilots, to sort of see where we could go, to really make a strong case for the impact, and to really solicit and get some sustainable funding. As the Assemblywoman stated, we've begun with Medicaid, right? So it's fantastic, so that I can take my dollars to support more training, more capacity building. As you said, we can't grow enough doulas fast enough at this rate. But there still is the risk factor. Not only Medicaid women need doulas.
Sure.
And so currently in our program, we don't say you have to be Medicaid or not. And so we do provide doulas for all women. Now that Medicaid is paying for the Medicaid women, we can then pay for the others if they meet our risk criteria, right? And so I'm hopeful that as we have Medicaid, which is a big payer on the table, we can get the private insurance side to sort of jump in as well. I say to folks, what do you want to pay for? Do you want to pay for the NICU stay at the millions of dollars, or do you want to pay this? You tell me, but it's on me to make the case and the argument that indeed what we are doing does impact the bottom line. So I think the programs are great, but I will also say we're asking the doulas to do a lot of different things. Collect data, partner with a community health worker, give us good information as to what is happening at these very significant milestone times, because I have to make the case that this indeed is being helpful. And so there's a little bit of tension because that's not their area, but it really is required. And so together we're working to really establish some real critical benchmarks so that we can make the case to private.
And outside of the program, just for the women looking for doula services, you can't get insurance will cover to a certain degree, other services. Insurance companies outside of what we're doing at the state of New Jersey Department of Health, if you were looking for a doula just to be covered, you can't do your insurance. There are some parameters and some paperwork and some buttons to press, but you can't get covered. Yeah.
How are you getting the word out about the doulas? Are these women dependent on the doctors to tell them, or is it right? Is this an issue? What can we do to help? I guess
that's a great question. I did not pay her to sit here and ask that question. There are ways. So through our program, the Department of Health is doing an amazing job of just making sure that clearly everything that we're doing is put through the state of New Jersey, right? Locally for Camden Atlantic City, it's a lot of our own partnership, but through SNJPC, we have we're on their website. We have our own Facebook page, Community Doulas South Jersey. We're doing our own outreach. We're in the big offices. We are open to come to any area that you are doing something in. You just want to do to speak, we will come and we will speak about it. So if you want to reach out to us specifically, visit info@cdosj.org. Jody, I did a good job. I'm doing it because Jody says you never give the right email. info@cdosj.org. You can email us there. You can also email me at ransha@cdosj.org. Jody's in the room. You can email Jody at Jody, JODI@cdosj.org. And we serve as the administration, and Helen, who is the third doula, who's our other supervisor, she's also there too. So we're here. One of our doulas is inside the room. Bahisha Beck, I'm shout her out. She's doing some amazing work with birth in Camden and also in the South Jersey area. And today, just to speak about that, I just want to tell you that we have our expectation was for us to do 28 births for Jody? 28 births, and we are now to 31. Yeah. So we're pushing, and ... we're now on our next cohort. So just as a note to all of you, we're getting ready to open up the floodgates for folks to come in and be a part of the next training for Community Doulas South Jersey under the Department of Health grant, Healthy Women, Healthy Families. We're ready to do a new training in July. So we're going to do an information session of meeting new women, African American women, women who identify as African American women of color who are interested in becoming the doulas. So we have a new cohort coming out. We're going to have a graduating class and a new cohort coming coming in, so thank you for that.
Question, that new cohort, will that still be limited to Camden and Atlantic City?
That is our 2 cities we're focusing on. So it is, you have to be, now for I want to make that very clear. You can live in the Camden, the South Jersey area, close to Camden, within miles of Camden, because in the doula world, it's a matter of being able to get there, right? So if we have a doula that's from Philadelphia, she's in the surrounding area, right? Doctors understand that. You got to be able to get there, right? And then Atlantic City is in the Atlantic County area, as long as you can get to Atlantic City, but we're serving women only in Camden and Atlantic City.
You can come to the cohort as long as you get that.
Yes, right. So if I want to make that very clear. The criteria is if you live in the surrounding area of the cities we're serving, then you could possibly become a trained doula. But you have to know that the women that we're recruiting is from Atlantic City and Camden. The clients that we're serving are Camden City and Atlantic City women. Thank you for that clarity.
And you'll get that word out.
Yes, so so the organizations, I want to also shout out NAACPs, bring us in. We want to come and support and be able to talk about this and want to take a deeper dive. We want to take deeper dives with folks because this is like, we're on the surface, but sometimes we want to get down to the weeds. We want to dig deeper into the weeds and talk about the things that we can't always say in these panels because there's so much to say. We want to talk deeper about some things that we're experiencing and being able to find solutions. I appreciate the nursing staff for being here, for saying there are some things that are not being trained. We want to de-silo this whole health system. It's very siloed. We want to de-silo it because everyone should be speaking the same language and we're really trying to get the same results, honestly. So yeah, we'll have that deeper dive.
Is there a question?
So Atlantic County is down there with Camden County in New Jersey's bottom of the barrel for our rates for deaths at the moment. So you were talking about protocol and we were talking about racism, implicit bias. What, if you were to, I guess, triage, like, what is the more important, what is the faster way to fix something? To go in and change the protocol of the hospital, or to find, you were talking about the implicit bias trainings being sort of silly. Is there one that you are familiar with that does do good work?
I don't know about implicit bias per se being a good program. I wouldn't say they're silly.
Well,
it's just some of the examples of racism and these things that you have to do. That's not what we're talking about. You know, they're not very helpful. I think the protocols really take a lot of that out of it. So it doesn't say, you know, if you're this or this, start with labetalol or start with Norvasc. It's if you have this blood pressure, it doesn't matter. This is where you start. If it doesn't work after so many minutes, this is where you go. I mean, it's very, it eliminates a lot of I think it eliminates bias, racial bias, racism. I mean, but it has to be enforced and the whole group has to buy into it. Maybe you could speak because I know you helped with it.
Maternal mortality is not a disease, it's a syndrome. And by that I mean there's multiple causes of it. And I don't know that it's a this or that. I see protocols as helpful to increase awareness and early recognition of disease processes that can be treated earlier and prevent the near misses than later. And there's a good example to show that in the United Kingdom, and they've been doing this at least since I was a fellow, which was 2 decades ago, incredibly, where every 3 years they publish a synopsis of every maternal mortality in the United Kingdom. And they look at what the common themes of those maternal mortality, and that's available to all in the United Kingdom. And actually my co-fellow in training was from Ireland and he turned me on to this. I wasn't even aware of this 20 years ago. And I got a copy of one triannual review and I read through it and it was very telling. It really increased my awareness as a provider. But that was more about, well, in this woman's case it was anesthesia, in this woman's case it was hemorrhage, in this woman's case it was hypertension. That's data, but that data then gets mined to come up with protocols. Well, how can we reduce the burden of hypertension and morbidity and mortality through protocols? And where nurses are great is they follow protocols much better than physicians do, truthfully. And nurses are with the patient much more than the physician. So there are eyes and ears if we're willing to listen to those eyes and ears. So I think what this has shown is that protocols help. extend that a little further in California, and I think New Jersey is doing similar things, they incorporate the public into their protocol. So the California Collaborative determined that 41% of the maternal mortality was preventable. And they devised both medical protocols to address that, but also public-driven initiatives. So there was coordination between the public, the health professionals, and the legislators on how to deal with this. I think the point about bias is that it's subconscious. So protocols are blind to race and blind to sociodemographic factors. So I think there's a lot of value to protocols. But where our biases come into play is if we don't initiate that protocol or we change that protocol subconsciously because we talk away certain things. Oh, she's not engaged because she's non-compliant, or she's not engaged because she doesn't care about the baby. That's almost never the case. It's always other factors that if we delved a little deeper, and we don't walk away that hypertension as, well, you know, she's just postpartum, we don't have to worry about preeclampsia or a lot of salt in the diet or whatever. So I think there is I don't think it's a bias or a protocol. I think it's a synergy between the two, truthfully.
And I think the protocols, if you're asking what would work the fastest, the protocols. They would work the fastest. And I because everybody has to buy into it, I definitely like the idea. And I think we even have a piece at our hospital as well. There's a piece of paper that they have in triage for family members when they leave about high blood pressure and postpartum, what to look for and when to call your provider, which is excellent. I mean, that's just ahead of the game. So that's first. The bias and the racism piece for me, that's a long story in the making to fix. I think that's going to be your slower piece. Probably, if I had to take a guess, the best way to start working on that is to actually check your colleagues when it occurs.
Right.
She's always like, oh, she was angry when she came in.
That's right.
You know, our pressure was like that when she came in. Oh, here they all come. Oh, she's never gonna push. Did you see that? She only went to 3 visits, but she got a better cell phone than mine. You know, it's the little things. Oh, did you see him? The way he was dressed? Oh, they're only dressed because he thinks he's important. You didn't really think about he got dressed, because every time he doesn't dress, he gets treated poorly. So maybe if I dress up nicely, you'll treat me nicely. So there's that is that's something that's not a medical school start, and it may never get corrected. It just may not for a lot, but it's something that does need to be recognized so that you can start working on
That's the first step.
You know, but the protocol, if I'm going to try to get past that first death or the first morbidity, yeah, the protocol helps. The hemorrhage protocol is great. And I'll tell you another reason why is because somebody like me, not all physicians do it, I'm up for 24 hours. And sometimes I get no sleep, you know, and sometimes I get an hour or 20 minutes broken. And it's very nice to have that protocol at 3 a.m. when someone's bleeding. The institution of the QDL versus estimated. It looked like a chuck, but it was really a liter. These are all things that, you know, oh, another thing I have to do. But when you really had to save somebody, that's helpful. The protocols that, you're right, the nurses they bring in the hemorrhage kit already. I forgot about that at 3:30. You don't want to know why? Because she was induced for 2 days, Dr. White. You know we have this here for you. Beautiful. It does. It takes the whole team, you know, it's the whole team that has to buy into it, and you have to be at a facility that does that. You're absolutely correct. You know, the golden hour, you know, I never thought about that, what you were saying. There's always a reason why you don't have skin to skin and breastfeeding isn't initiated right away, because I'll be honest with you, I take it for granted. I don't get a lot of excuses. If anything, I have NICU standing over there waiting. Can I still have delayed cord clamping? A baby doesn't look... You're fine, you know, and take a blanket and stimulate the baby right on, Mom. So I take those things for granted sometimes, that even here, you will have other hospitals that may not do that. But I think the protocols is the initial step will help, because you don't have to think too much about it. And if I do have a bias, or if I'm racist towards something else or somebody else, it takes that out of there
And protocols
initially.
can be state, not just hospital.
No, that's good.
Sorry.
We're working with the New Jersey Hospital Association to make them statewide for all hospitals. I want to say with the C-section bundles, I believe we have all hospitals who've signed on. But I feel like I just want to comment on there's no quick fix. This is and you know that, and I think that the implicit bias and the training is really designed to sort of disrupt a system that has been operating this way for 400 years, right? So we're really trying to undo many of these things, and I think from where I sit, Assemblywoman talked about the fact that I work with my colleagues from other state agencies. I wish it was just a health solution or a clinical solution, but it's not. It's about housing, transportation, what is the diet? How are women operating during that interconception period? Are there fresh fruits and vegetables in the neighborhood? I mean, I say this because I go out and I talk a lot about the doulas and the work that we're doing, but I did an event in East Orange that will stay with me forever. It was about promoting breastfeeding in the African American community. Nice, WIC clinic, babies, moms, and all that. But yet, when we heard from the mothers, and the mothers started sort of speaking to their stories, it wasn't about breastfeeding. It was about, I had a baby and I was waiting on my temporary disability insurance check or my family leave check. And when I was in the hospital, I didn't know if I should think about giving this baby up for adoption because I was about to be homeless. So all these things about all of we're worried about breastfeeding and all that, and the mind is worried about, are the lights still going to be on when I get this baby home? Where do I live? Do I feel safe? Does my partner or husband have a job? All of these things are all of these stressors, right, that do not create for a good situation when the doctors meet the patient at delivery time, And so I think a lot of the work that we're doing is this work, but it's also working with folks on how do we expedite temporary disability insurance. The moms that I talk to are making hard decisions because your Department of Labor system is jacked up. You need to do better. How do we make sure people get emergency child care, transportation, that you're not calling a 1-800 number and getting click, 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 and losing hope? All of these things. How do you acknowledge that postpartum depression is real? And a Black mom is not afraid to say, I feel down because here comes DCP&P to come and take my baby. When what I'm experiencing is very normal. And so a lot of the work that I do is actually not necessarily health work, but really working with my colleagues in the system to develop a system that supports these families. And so we've spent a lot of time and investment in community health workers that we partner with doulas like her that are navigators and really help people get to what they need when they need it so that we can get the outcomes that the docs, and the nurses and the rest of us are all looking for. But I wish it was as simple as a protocol or skin to skin and all that, but it's life, like that Maslow's hierarchy of needs, right? We got to get here first before we get to the summit, and I think that is what we're really seeing with the families that we're working with.
May I add something to that? I think you hit on an incredibly important point. I think of it as trees. There's the trees that exist that we have to support. That's where protocols can really help. And then there's the trees who are growing from the seedling up to the tree, and that's where all these things can help. As physicians, we're very focused on medical protocols because that's real to us. How do we prevent and treat hypertension, et cetera. But I'm proud to say that I've seen a couple things that Virtua has sponsored that has really made an impact in my patients' lives. One is transportation. So at one of our campuses, folks are less socioeconomic means than at the other campus. So they provided this pilot ride service that we can prescribe almost. As doctors, we're used to thinking of, do I have to prescribe you amoxicillin, or do I have to prescribe you a prenatal vitamin, et cetera, et cetera. But we don't think in terms of, as well, do I have to prescribe you a ride service so that you can get to your visits, so that I can engage with you, or vice versa, actually, you can engage with me also. And secondly, there's a mobile farmers market But it's not just a farmer's market. I think Virtua realized, for example, that those folks have other needs, to your point, and they get hooked up with a social worker at that time too. So you get fresh produce. And by the way, we are just touching, in my own life, in my own personal life, I'm taking a phytonutrient journey. And as allopathic doctors, we have failed to understand the impact that nutrition and other things can have on health. And I think we're just beginning to learn that. So hooking people up with fresh produce, which they might not have in their community or might not have the economic means, but also hooking them up with the social work support that they need to get back on their feet, for example, if they're going through a transitory time, is all going to be part of it. But that's the nurturing the seedling. The protocols are for the trees that already exist, I guess.
I just want to support that. This is kind of tie this one in, but on a doula side and just dealing with infant maternal health, there are some things we can do that's kind of prior to getting to the point where we're looking at protocol, and maybe we can put it just as in the context of how do we really deal with community partnerships. I think that hospitals, when you're dealing with service and you're dealing with people that are coming from the community that surrounds the hospital or people coming into that hospital, there has to be a community partnership that really speaks to the value of what patients need inside those hospitals. And what we're finding is that the hospitals kind of sit in a bubble. And it's not really a true community partnership of a pipeline of community people going in and out that hospital that's constantly being able to sit at tables. They may not have the letters behind their name, but their experience makes them an expert in certain areas. Does that make sense?
Yes.
So in partnership, we're saying that we need to see that happen more often. I'll give you an example. Dr. Berger from Our Lady of Lourdes, head OBGYN there, in the emergent, still in mind. Have a moment. He came to SNJPC and said he cannot watch another mother or baby die in his watch. He said, I need your doulas. I need them to come into this program. He said, right in the heart of Camden, New Jersey, they have Osborne Clinic who deals with a lot of black women who are pregnant and also going through their process. And he made it important to invite doulas to come to a meeting with him to say, we are going to roll up the red carpet, not because being a doula is so sexy, it's because I can't do this on my own. I need the support of women seeing themselves in you. The women that I'm serving look just like you. Need to see you. They don't need to see me. They need to see you. And we can support each other. I also want to build blocks with you to say, what can we do to support you? How can we help you not feel like you're not a part of the team here? So we're building that relationship with them, and that community partnership beyond the Department of Health grant will still be there because the doulas that are serving in Camden are in the city. So now we can go into Our Lady of Lourdes and see many of the OBGYN staff that are saying, hey, so-and-so, look, the value that's in that, like me, a mother from Camden, going to a hospital and I have a doctor saying, hey, you're here for birth? We're having a conversation. It's not to take away all the loans and stuff you guys have to get. I'm not reducing that. I'm saying that the spirit of us have this new engagement that wasn't there before, where you can hear a black woman's voice beside that space and saying, you have something to offer to my plethora of knowledge that I've gained over years of being in this practice. The second thing is that being a part of Ground Rounds, we were in a room of obstetricians that or gynecologists and staff and nursing staff that were able to have dialogue with doulas. Like just having a conversation of what can we do.
You're giving me a great idea, actually. The light bulb's going off.
I like when light bulb goes on.
I would imagine that creates trust between the patient and the physician. In this case, I mean, it could be a nurse, midwife, whatever. And that in of itself helps breaks down
a lot of bias barriers. Yes, it does. It does.
That's a great idea.
So when we do that, I see your hand. I'm gonna move on. I just want to say that. So, but that, and then also the Ground Rounds being a part of those conversations can break down a lot of those biases too. When you're having direct conversations, we're taking out the funk inside. I say words like that, funk, because nurses don't feel intimidated. Doulas feel they can talk to this nurse directly. There's no power struggle there. It's just we're here for the same reason, right? We're here to help mom. That's it, mom and baby and family. Referrals to the program. Imagine doctors saying, and you're prescribing transportation and prescribing medicine and things to help mom. You're saying, I want to prescribe this doula for you. Call this number and see if you can get involved in touch with this doula. I think they'll be good for you, right? And then partnering, that partnership with doulas moving forward, like other things we can do beyond just actually in the labor delivery room, what are the big events we're doing in the community that are highlighting those that have a voice inside those spaces? If you're doing a big health fair, you're doing a big event where you're bringing in some of your funders, you can say, this is what has helped us to be able to up our numbers and reduce these numbers. That is important in partnership. Yeah. So take them all. Come back, call me back. Take them all, call me back.
Call me back.
There was another question from the floor?
I actually like to make a couple statements addressing 2 points that were just made. One quick, which is solving racism at the hospital can only go so far when society is racist and our president is supporting that. So, and also with food and electricity, will my lights be on when I get home? So you're sort of like trying to solve all of the problems in that pregnant woman's life because what choice do you have? But it can only go so far. You can only do so much when society doesn't, you're on a foundation of quicksand. But the larger point I wanted to make was I couldn't be more proud of my wife. We did a lot of research, and she gave 2 natural births with no drugs, no procedures, and she was in the gym twice a week up until 3 days before our first was born. And
to meet her.
But no matter how privileged you are, birth is not for the faint of heart. I mean, my oldest one was in danger during his birth, and my wife was in danger during our youngest birth. And on top of that, to have racism is just, birth is difficult enough as it is.
It's a recipe for disaster.
I think you said something really important. You said, I'm proud of my wife.
Isn't it something?
Yeah, that's an important statement.
So we had a doula both times, and my oldest, who was 3 when his little brother was born, we got a doula for him so he could be with us in the room. And for-profit healthcare has stolen the birth experience from the family and the mother and society and the community. And I see doulas as being trained in the for-profit system and trained in that experience as it used to be before the for-profit system. And doulas create a space to be able to have a natural childbirth in a corrupt system. And they can also help make the decision of when is it time to let go and that we do need technology because things are just, 90% of the time it's fine, but 10% of the time you really do need to let go and we need that technology in order to save their lives. And that's it.
Great. She had it earlier.
If you don't mind. So one of the things, and this is addressed nationally this year at a rather large nursing convention down in DC through the Institute of Health, and one of the problems that has been very quiet, but our nursing communities do not reflect our communities. Only 10% of the nurses in America are African American or Black. And this is something that needs to change because the problems that we see, if you go into any hospital, and if you're in a Newark, you're in a Camden, a Patterson, or anywhere, when you come in, and I've seen it bringing patients that are pregnant to facilities, and it literally, it's heartbreaking. I've had EMTs I work with just say to me, if someone touched my wife like that, what would I say? And it's an issue. We have to really work at developing in our communities too, young men, young women from the time they're in high school, developing paths for them to become nurses. And even more importantly is to get involved in maternal care, NICU care, where they really are going to make a difference. The other thing I have is about training and protocols. And one of the things that we really do need to do is invest in that training. A lot of the training that nurses receive, believe it or not, is on a computer system. It's a point and click, a point and click, a point and click. And these nurses are doing it in between patient care. What we need to do is have sim labs, to have an opportunity for these nurses to work multidisciplinary teams with a doula, physician, or resident, having where these complications are happening. It could be an emergency room scenario of a pulmonary embolism. It could be in labor and delivery where now you have an emergency C-section. It could be in an ICU with a patient going into HELLP syndrome. I have a friend who's a professor and she teaches nursing up in Chamberlain, and they actually used Lauren Bloomstein, who was a nurse from Morristown. She unfortunately had died, went into HELLP syndrome. Her husband was an orthopedic surgeon. She was a NICU nurse, and she died in a New Jersey hospital because signs and symptoms were missed. So what that school does with their nursing students is they use that sim and they recreate it so that there's an opportunity to say, well, this was a sign and symptom that was missed. What would you do? There's so many publicized cases of this. Judge Hackett's daughter, another one, delayed. What could you do? What would you do?
Yeah.
There's so many things. This is where we need to invest, because doing that sim lab, doing that multidisciplinary, having a symposium, we don't get education like this on a regular basis.
I think that's an important point.
We need that for muscle memory,
because,
but that's what we need to
you know, we had a mantra in medical school, see one, do one, teach one.
Exactly.
And at first, we just kind of said it tongue in cheek, but in reality, you could have all the protocols on earth, but if you don't practice it. So, for example, at Virtua, we do have SimLab, and we simmed out. We had a need a couple of years ago, to your point. We weren't doing hypertension well. So we developed a protocol, but now we sim it. So forget racial bias, there's medical bias. You know, that's shaped by the last 9 patients you've seen, you know. So this helps get rid of the bias. But I really enjoy, one of my passions is medical education, so I lecture a lot for CME.
I write CMEs.
And what I have seen, I've been lecturing for 20 years now, what I have seen shifted, at least in the organizations that I lecture for, is there are didactic lectures, but there's more and more case studies where you break out into smaller groups with the audience and you go over cases, the good, bad, and the ugly. And to your point, I think if you only practice the algorithms, that's the only way you're going to follow.
I mean, one of the things too, for the Department of Health to partner with the Board of Nursing. What if, because maternal death can happen anywhere. Someone can be readmitted, they can go into a med-surg unit, a telemetry unit, an ICU, L&D, emergency room. So other than the pediatric unit, they can wind up anywhere in these hospitals. What if there was, every time we renew our licenses, we have to have so many credit hours within a certain guideline. So a lot of times, I think now we're still doing, I think we're doing opioid, which is like, right, so that's one of our mandatory things. Could there be developed something that's mandatory, like the opioid or child neglect abuse, it's a Pennsylvania one, that nurses who are emergency telemetry, medical surgical, L&D, ICU, where this is part of their every 2-year renewal.
Not just nurses, physicians.
Right, but I'm saying for our, just like, I'm just thinking, because there's so many of us.
But no, to her point, to your point, not just the nurse in the ER or in the ICU who only deals with the pregnant woman, you know, once in a while, but the ER doc and the ICU doc
I mean,
also.
Could there be where there's a live or like a webinar based for the initial, and then that every 2 years?
I think that's a great idea.
Type of a thing.
Yeah, that could be instituted, but I know where I trained, they had the same guidelines and algorithms for us. And they actually went to every shift and taught the emergency room and the ICU about the pregnant woman and the postpartum woman. Every person that came, we had a triage area for obstetrical patients. But every patient went to the emergency room because they felt as though if she had a pressure of 190 over 120, pregnant or not, any person would be treated in the emergency room. And they had already instituted a Foley catheter, magnesium sulfate. They had already got an IV hypertensive while I was being paged as a resident. There was not one patient that went through that emergency room, through the hospital, not stabilized. And it took the initiative of the chairman, the department chair, to actually physically go there and do that with the ICU so that no one got missed. You know, I mean, that's how it worked there. And it doesn't take much to do. And that's why I still believe, and it's you know, one aspect is, well, we're rushed, we're doing this, we're doing that, and the other. In my mind's eye, any postpartum pregnant woman That's unacceptable answer. It's too rushed. 190 over 120 would not be ignored and shipped to the ICU if it were a man. It just wouldn't happen. It would not happen. So we should all be treated the same. It is a disease, it is an emergency, and it needs to be stabilized.
But even in triage, when you're triaging in emergency rooms, and we've surveyed nurses in New Jersey, so we surveyed in the
It's
national
education. That's all it is.
as well. Not every emergency room in New Jersey, their software does not have in there, have you delivered a baby within the last 365 days?
Correct.
So this is where sometimes things get missed. And most nurses, when we survey them, and we survey on a almost more than quarterly basis, and we have breakouts. I actually have to run to Edison because we have a chapter meeting of 55 nurses, where they're even saying as labor and delivery nurses, they're getting their education, but the rest of the entities may not be getting it. And that's where, we need something that's going to be across the board.
That's right.
Can I just say one thing? I think that Lisa had brought up that in New Jersey is more active than I think in this room suspect. That there are many of these initiatives that are in place in almost all of the different regions. And I know from the institution that I come to, the simulations for our department, because our department is the one that sets policy for our department, that they are mandatory. We have mandatory simulations and you can't renew your privileges. You can't come there if you don't do
like the hospital system I work for, 16 hospitals, and they have one educator for the NFM program, which is specifically dealing with maternal complications.
Right.
So it was failing in that system, and we knew it, we identified it, and the excuse was, well, we don't have an educator right now. And that's not New Jersey, it's a completely different region of New Jersey, but this is why, again, I'm very passionate about this. My colleagues, the 4,000 nurses I deal with, are very passionate about this, because these are the people at the bedside that if there's a mistake, they're going to catch it. But they have to have the education, they have to have the training, they have to have enough staff to do it. If there's a nurse that has 10 patients in the ER, or I've heard of someone who had 22, it's legit, I've been there, I work there, it's not safe. They have to have eyes on. They have to have that ability to take care of that patient. Those are the things that we as nurses, the bedside nurses that are literally hands-on with the patients, have been crying out for.
I just respect where you're coming from, because I think that if this wasn't a setup for this kind of conversation, there will be some things missed, right? And I think I hear your passion and your cry out, because this, even the point that we raised, I didn't want to move over that about it not being enough African American nurses being trained and certified in these areas. Those are issues, right? But then you have you speaking openly about things you're trying to correct. Like you're check yourself saying, I see issues. I'm trying to get the people who are higher in protocol than I am to see that down here, because they're nurses on the ground. Nurses are on the ground to us because you're constantly dealing with patients every day, right? And you also are the communicators or quarterbacks to what happens throughout the rest of the day as we change shifts. Because you may have it, from my personal experience, I've had great nurses and I had a shift change and I had the nurse from hell. You know what I mean? Like, whoa, go back to the shift we were just on, right? So it happens in these settings, but I appreciate your voice and your advocating, because that, I think, has to be looked into as a deeper dive we can have it,
I apologize, I have to.
Well, we certainly want to thank Dr. Shaw for his
I apologize for leaving early, but I'm actually getting an acute hypertension emergency when I talk this afternoon. And I just want to say to my co-panel how articulate and a couple ideas are swirling in my mind, and I appreciate being able to speak with such a passionate group. Thank you very much. I appreciate it.
Thank you.
It's appreciated.
Yes.
So on the other side, I'm not a frontline healthcare worker, and as you can see, I'm not Black. And I just want to say a couple of things that I have learned in the space of, policy advocacy that many of our partners have taught me. One is as a white woman, being aware of my privilege. That was new to me. I'm just like, well, I just think everybody should get along. We all love one another. But that's not how the world works. And so I just want to encourage all of you, people in the room and on the panel, the thing that really needs to happen, and I feel like the momentum is really there, is that the discussion of discrimination and implicit bias has to be public, right? This is like, we need to talk about this everywhere, in everything we do and in every policy we talk about. That has to be a piece of it. And I really feel like there's like a new awareness happening, and I think it's really good. So thank you for that. On the side of the structural piece, right? We do a lot of work with our partners around access, right? We still, in the context of where we are in this country, we're still fighting over whether or not maternity should be a health benefit in our nation, right? I mean, this is like egregious in 2019. We're even having that discussion. And I had that discussion in a local congressional office. I mean, it's something we have to be aware of and continue to fight to change. But the other thing I wanted to ask was, Assemblywoman Sumter talked about the Medicaid coverage being extended to 12 months. Well, that bill's held. That didn't happen yet. There's a lot of interest, and it costs about $20 million. Right? How much do you, as frontline workers, see that impacting? We're very interested in seeing that move. And how important do you see that in the context of where we are right now? Like the urgency of that moving is my question. So I'd love to hear what you think about it.
Well, I think we could probably, maybe we should all, kind of like just speak to that. So I'm supposed to be the moderator, I'm not supposed to be part of the panel, but I'm an obstetrician and gynecologist, so I can't help but jump in that a little bit. So that's extremely important, because as we look at different health, issues, and as we move, through the postpartum period, we know, taking for example, diabetes. Okay, so we know that if you're diagnosed with diabetes during pregnancy, that at 6 to 8 weeks postpartum, okay, that you should be screened again, okay, for diabetes, and that you may continue, okay, to need services with diabetic education and treatment as you move on into the pregnancy. Same thing with cardiomyopathy, which is one of the substantial causes of death. Okay, so that can occur up to a year postpartum. So people, they really need to, if you're more hypertensive, they need to be able to touch base, okay, with your provider, and you need to have the means to enter into the medical system and to have medical care so that you can have further testing, diagnosis, and that if there are issues like that, it can be taken care of. So almost everything that happens, as you look at on the continuum, what we used to sign off as, Dr. said, at 6 weeks, okay, that really was, that is not the appropriate interval. Now we know that we must do longer and we must do better. So that's my 2 cents.
I would say it's very urgent, and it's something we have to do. One thing about is presumptive eligibility. So that women, when they're pregnant, can be expedited into Medicaid, but often they wait. And we also know that presumptive eligibility will cover people who are even undocumented. And we know that there's a certain pot of money that is available July 1, and it's usually finished by October. And so we really know that there are needs there that are being unfilled. I say all of that to say it's urgent, we want it and everything, but if it costs $20 million, are we ready to put our money where our mouth is really the question. And so I believe that is where some of the stall is. But I think, as Dr. White said, you look at maternal mortality, it's not necessarily during pregnancy or the day after. It's 42 days after, and then we even track it for a year after. And people are still dying within the first year. So imagine if you're not covered. What hope do you have of any type of survival, really? And so I think that those are the conversations that are ongoing right now. But I say to folks, this is our time. This is our moment. If we're going to try to fix this or create an infrastructure to fix this in New Jersey, it's right now. Because there will be another issue in 5 years from now. I've been in the department for 20 years. I can give you 10 good issues that have come and gone. But the issues are still here, right? Pediatric asthma, this and that, and emergency preparedness and all of that good stuff. Still issues, but the spotlight is not on them the way the spotlight is on this issue right now. So in my mind, I say to my staff, I say to my colleagues, this is our moment. If we let this ship pass by, we shouldn't complain about it to anybody but ourselves, because we allowed that to happen. You know, coming together on a Saturday like this, having a diverse panel with diverse ideas and solutions from the audience. You know, you guys are giving us solutions. You're giving me things that I'm going to think about implementing Monday when I get back to the office. This is really important, you know, so I can't thank the NAACP and all of you enough for just creating this space for us to have a real, frank conversation.
Just one.
That's okay. I was just wondering if I could share this with you. I told you I was a retired nurse, and I wrote this a few years ago, and it's called Motherhood. And my daughter had that HELLP syndrome, and we were driving to Virginia. I could not remember. I was hearing all the symptoms on the phone, and I could not, for some reason, remember HELLP syndrome. And my husband was watching a football game, and I went into the room and turned off the TV, and he said, she's never done that before. Something's going to be wrong. So I said, we're going to Virginia. That happened with my daughter. Everything worked out. And with my daughter-in-law, she had high blood pressure, and we were in Atlantic. She was going to deliver in Summers Point. And I'm in the waiting area on my knees praying, Lord, please, can we just get this baby delivered? And thankfully, everything happened, worked out for both of them. But I wrote this a few years ago, and it's called Motherhood. I just wanted to share it with you. It's a little lighter than everything we've been talking about. While enjoying a glass of iced tea last summer, as I said, I wrote a few years ago, after picking blackberries from her garden, my friend Donna and I discussed the familiar subject, motherhood. That perfect/imperfect phenomenon experienced by the majority of females. What is happening with it in today's society? Donna and I worked many years as registered nurses in the maternity unit. While I have been retired for 40 years, she continues her career as a lactation consultant. She remembers the stories about her grandmother delivering twins. A family member or a neighbor lady came to the home and literally took over all the household duties while grandmother only had to concentrate on her babies. It was probably a week before she was even allowed downstairs, and at least 6 weeks before she went out of the house. All of this came to mind when I recently cared for my own daughter after she delivered her second child. We were able to modify Donna's grandmother's care. My daughter came downstairs after lunchtime and went back up at bedtime. She was able to stay homebound for a few weeks and out of work for a few months. Thankfully, her mother-in-law and I were able to help her and her family. I remember instructing patients to take it easy when you get home. Let it be 4 to 6 weeks before you're back to your normal activity. They were encouraged to let the family members care for them. Perhaps some of them followed these instructions, but I am sure that for others, my instructions were falling on deaf ears. There are so many distractions. The 21st century holds a totally different standard. Too often I've seen the tiniest newborn babies at the mall. The new mom needs to spend more time with her baby. The outside world should be shut out. She needs more time to be pampered. She should be encouraged to have that heart-to-heart conversation. In this quest to get back to normal, we speed up the healing process. It makes that special time appear insignificant. It takes the uterus a full 6 weeks to get back to its normal size in the pelvis. It's okay to play the role, as I used to tell the patients, and take the time to just kick back. Have we allowed motherhood to be lowered to some substandard state? Have we given it a lower priority than it should have? It should be regarded with the highest esteem. It should be relished. It must be cherished. It is nothing to be taken lightly. It should not be approached or even considered unless everything is in order. The individual needs to be intact. She needs to be educated, mature, financially stable, married. She should be surrounded by family, friends that can support her, both physically and emotionally. There should be nothing else with which she has to concern herself. This new infant should be the all-important focus. Entering into this state unprepared or unequipped propels a young person, teenager, into some kind of quantum leap. Any act that would thrust a young person into motherhood should be avoided at all costs. It's not a joking matter. It may look easy. It may look like anyone can do it. Not so. It is filled with all kinds of traps and pitfalls. It should be approached with caution. First of all, it is meant for the strong. Weaklings should never consider it. 24 hours a day, 7 days a week is a daunting task. For a young person to stand at the portal of the unknown is frightening. When a young mother would go home with her baby, most of the time the teen was too naive to realize the danger she was approaching. Thankfully, she had her own mother to guide and buffer her. You can't teach everything she will need to know. A 6-week course won't do it. Even a semester in Motherhood 101 will not be enough. Unfortunately, it becomes a job training. Maturity is needed because it is life experience and skills that are drawn upon. That is the very reason motherhood should be delayed until all of the woman's aspirations have been achieved. Can we dissuade this next generation? We can give them all the warnings and reasons to wait. What they really don't want is motherhood. In a scene from the movie A League of Their Own, Tom Hanks' character says, "There's no crying in baseball." Well, there is crying in motherhood. There are tears of joy at the delivery and baby blues tears a few days later. There will be tears of pride at every future accomplishment. There are tears of sadness, a miscarriage at 7 weeks that robs one of motherhood. Then there is the major grief of the perfectly normal stillborn. There are the accidents, a 3-year-old in a pool or a newly licensed 17-year-old. Then there are the tears that say there are no guarantees in motherhood. There's also praying in motherhood, as evidenced by the comic strip character Mama, as she kneels, and I'm sure on her callous knees, and says, "Lord, it's me again." Through all the ups and downs, good times and bad times, we wouldn't trade it for anything. There is also redemption in motherhood. It is called grandmotherhood.
Well, one more question, then we're going to resume with Dr. White's comments.
I want to make one more statement, which is Dr. Shah mentioned earlier that we have, the United States clearly has the resources to give our people what they need, doctors and medical stuff. So nurses, when they don't have enough staff, they have to triage their care for the patients. Hospitals, when there's an emergency, they have to triage the care for people. The state of New Jersey has to triage the limited tax revenue that it has in order to give its people what they need. But I give lectures on economics. And what's different is at the federal level, they create money. So if they have the resources, they can create the money and it doesn't cause inflation. But they pretend that they can't give us health care for all. They pretend that they can't give us free college and so on, even though we have the resources, and they create money. So that's just silly. So because they decide not to do that, that puts pressure on the states and forces states to have to triage, forces states to have to extract more from their citizens because they can't create money and they need money from their citizens. So this energy that we spend trying to pressure the state in trying to give people more of what they need, some of that energy should be spent instead forcing our federal representatives to stop talking economic nonsense and pretending that we have to triage at the federal level. Because at the federal, government gave us what we needed, it would remove pressure from the states, which would remove pressure from the people, and would change everything. So yes, we should be pushing the state to do what it needs to do to give, but they would be so much less limited if our federal government stopped pretending that we had to triage our money, when clearly we have more resources to stop the suffering of everyone.
Christine.
Doctor, did you want to just resume? I think almost in line with what you're saying, in the extension, okay, of prenatal care, the benefits up to 1 year postpartum. Did you want to make?
Yeah, I mean, I definitely agree. There's an urgency towards that, but with what you were saying as well, when they looked at it about dollars, it's just not about dollars, because we got more dollars than most of the countries and we're still doing poorly. But I think conferences like this, and particularly the program that you are involved with, I think it's about where are you putting the resources, really, that are going to give you the most bang for your buck and are actually what the group that you're trying to help, what they're asking for and what they need. And if they don't know, sometimes you don't know what you need, okay? But if someone could just ask me what my issues are, then you could help me figure out what my need is. So I think it's not just about approving the dollars, but making sure that you really have the right programs for it. Most of my family's in education. There's more money dumped every which way and special things, but it has to be really for the people you're trying to service. So I think this sounds awesome. I'm involved in a volunteer organization, and they're about supporting doulas in communities with people that look like the people that you're trying to serve, because that is important. And it's not just to say that you look like me. I think for most Black Americans, and I can't speak for all, just from the history of the country, there's a lot of misconception, there's a lot of fear, there's a lot of mistrust, and that crosses all socioeconomic levels for Black America with anything in medical care. And that goes across generations up until this generation. So, and there's a lot of racism that's occurred, not just in the medical field. So if you almost have someone that's an advocate of yours in the medical field that can understand you, and I like the fact that you say you have to come from the area as well, you might listen. And if somebody else in your family listens, that's even better. And you're absolutely right. There's nothing better than to come into a hospital and somebody you're with, they say, hey, how are you doing? Okay, I'm in good hands. Here. So it makes a huge difference, So it's not just about the money. It does help. There's 22 million, there's probably 50 million, there's probably more than that available, but it's also big on, I like that, I'm thankful to be on this panel. I really see a lot of positive things in this area that are going on that I really truly believe it's going to make a big impact. And Jody, I didn't realize you were involved in so much of this. She's a midwife I cherish. A doula, I'm sorry. A doula I absolutely cherish. I'll just never forget one patient we had, I even asked, she said, I think we tried it all. I said, you don't have anything else in your bag? She never asked me. You gotta have something else, the chandelier, something. She's one of those. And then by the same token, what I appreciate about Jody is that I had another patient that she was always anxious. Everybody was nervous about seeing her because she'd take up an hour in your office easily before you could get to the exam. And I said, you need a doula. Because I could see this isn't going to go well. And Jody saw her evaluator and she called and she said, I have a special doula for her that also specializes in mental health. And this is going to be perfect because she needs a combination. So these those two aren't separate. There are a lot of issues. They're not separate, you know.
I'd just like to, just a very brief response to what you just said, which, no doubts that in some extent there is money, and then it's just a matter of making decisions on how to best use it. If people understood how the federal economy works, which most of us don't, I'd be very surprised if more than a very small amount in here understood that we could let go of a lot of the nonsense that we focus on and focus more directly on making those decisions. So,
Thank you. And I just want to make one comment, you know, about race. I think there's no question that we all know that racism, exists in our country and exists in our world. Okay, that as I see it in terms of one thing, would change. People obviously they have to check themselves. They have to know themselves. Everybody has bias, and there are people who are racist. Okay. So the question becomes, I guess, in medicine, is it institutionalized, medicine? Is if I went to hospital A, because of the color of my skin or my ethnicity, I was treated in a certain way. And I know that Alyssa certainly knows, okay, because I know you deal with statistics, okay, that these things actually can be proven, okay, that the community, can demand, okay, to know why is the outcome worse for Black women. And, all hospitals just have quality committees. They have root, cause analysis. This has to be taken seriously. So in other words, when an African American woman or Black woman, if there is some adverse outcome, then this has to be in a systematic, fashion evaluated, and race has to be, one of the things that has to be looked at. And obviously, it becomes evident by the numbers, okay, and other thing. And so these techniques certainly are used in many of the hospitals, okay, and certainly it's used, by the health department. I think that we're going to start seeing more and more of this come to the fore.
Yeah.
And I'm sorry.
Yeah, I just want to respond. I appreciate you saying that. I just want to respond to that, and I see the question before. We have to also unpack that there's just a systemically, we've always. Historically, we've always used African Americans as catalysts for experiments. And we have to be really honest about that in the setting. And I don't want to play with that. I don't want to cringe on that. I want to be clear that Black women have been used as lab rats. Our wombs, our body parts. Black men have been a part of experiments for years to advance medicine. Right. So we can take a walk back down that line and remember that there was medication at the time. It was not as evolved as it is now, but Black women weren't being offered that medication. They were being used to see how much pain they can take when they're being operated on openly on tables with a bunch of white men around them, seeing if they could, we can advance medicine on this person, and it's happened over and over and over again historically speaking. Same thing with Black males. But since we're talking about Black women, the fact that body parts of one individual woman has been harvested for years because she was looked upon as a freak of nature because she did not look like the average Black woman or woman in general. So we want to talk about the historical context of how Black women have been brutalized for years and used as lab rats or test dummies for experiments that now, moving forward, strains of our DNA are cures for advancing cancer, supporting cancer treatment and things like that. So I make that statement to say that it's not really changing. I just want to say that, I just want to be honest about that. It has not changed 100% because, again, if we're looking at how, and I'm being honest, how African American young women are being pushed to surgery faster than given the option of going through a natural childbirth or a vaginal birth, it's still the same. That womb wellness, the fact that our wombs are being scarred and scar tissue is coming in our bodies, and we don't know why we cannot have babies and how come we're getting sterile at an early age, is still based on those same symptoms, that same ideology. I'm not speaking about this staff up here. I'm saying that how some doctors are pushing women to have C-section because they want to be free for the weekend.
Or higher reimbursement.
Thank you. So the point I'm making is that conversation has to be put in this space, and it's about the mentality of how America has always treated black women and black people when it comes down to surgery, when it comes down to medicine, things like that. And I just want to touch on that for a second.
Can I ask you to just expand on that point? So then, how do you suggest that we move past that in our community so that history does not become an impediment to our people entering into the medical system and getting the care that they need?
I just think it has to be a rule. I know it's not, I don't believe about it can happen right now. Yeah, but the victories are small things we're doing like this. What are we going to do post this to go back into these facilities that we all sit at major spaces or departments heads, or we're able to have the conversation? Because when I speak, you might not hear it, but when other races speak, you hear it very clear. So how can we take it and interpret it in a way that we are really creating change? Right? We're giving the opportunity for people to see that we're not going to continue to do this over and over again. And then I do want to be clear that if we continue to allow the tables that make a decision to be just men, and I want to be very honest about that, it's never going to give you the results that we actually need, because the experience comes from a woman. And that has to be said. It's not about dividing us by sex, age, or anything like that. It's about the truth. I would not want someone to make a decision based on what's going on in my hoo-ha down here, and I'm asking a man to give me that advice. I think that men do a really good job of knowledge base and being able to get content information also from their experiences, but some things change. And women can be able to have those conversations sitting at those tables saying, but did you know that this is the case with that? Did you know the woman at this age and this race and this, with these things going on in her lineage, this has happened to her? Those things have to be discussed. So to answer your question, I don't have the quick answer, but I do know it starts here in this space right here with all of us being able to use our voices to impact the change that we want to see, starting in hospitals, starting in spaces like this, starting where we won't have this dialogue with community people who are another Rancha in another area, Rancha in Voorhees, or Rancha in Maple Shade. Where are those people at that we will not allow? We sometimes separate the classes. And I'm being honest about that. We don't want to have that vibrant mom who may not be, we might call her, she may be a little more colorful than we want. However, she does bring a base of expertise to that table that needs to be respected and accepted based off of her living and learn process through what she's been going through. Is it what you want? No. Is it out your comfort zone? Absolutely. Is it going to stretch your edges? Absolutely. Are you more educated than her by book? Yup. But have you had her experience? Absolutely not. And that makes her the expert beside it. So how do we create those tables where we get past that bias? We get past all that prejudice. We get past a lot of that, the spirit of our impressions on what we believe it should be and how a woman should come into a hospital, how a woman should be a mother. How do we unpack that in a way that we're now accepting what we see, accepting what is going on? I think that is the valuable conversation in this space, to make sure that as we walk away, we're taking that with us and saying, I'm going to sprinkle this all across this room because we're all guilty of it. Right? So yeah, I just wanted to share that with you. That's all I had.
Hi. My name is Lisa Bernardo. I work in home care. I do not do OBGYN. However, I had 6 high-risk pregnancies. I have 5 kids. So I'm an expert because I went through some weird stuff, and also because I work in home care. So we're talking about money. We're talking about $20 million, and that's a lot of money. I'm trying to think about how we can make effective interventions, and a lot of that is going to be on data that we collect and also data that we already have. So I'm not sure what Tammy Murphy's task force is looking at, but do we have, my question is, I don't know if anyone can answer.
Yes.
Are we looking retroactively at what data we have so that we can really get a good picture? The other thing is, when someone comes in to deliver, do they get home care? I was lucky. I had, for several of my pregnancies, I had 1 or 2 postpartum visits. But that was often not the case, and it's not standardized, because if you don't have, say, Medicaid, and like say if you have private insurance, which I had for my first 3, it's very spotty what the benefits that you get. So if we could standardize that, and if we have gaps, That's when we need to look at a state program. We also need to make sure the insurance companies are giving data. We need to study this because there's a lot of reasons. And there is systemic racism even in healthcare. I was in a room full of nurses. We were in a class and they were saying, oh, we give them rides to appointments, we give them food stamps, and they're still having preemies and they're not coming to their appointments. And I'm thinking, yeah, okay, well, if you can't find childcare for your other kids, you're gonna have trouble even if you have a ride. Like, people just don't understand, so we need that documented, we need it studied, and that can be done a lot with retroactive data that we already have available, I'm thinking. But I don't know. The other thing is epigenetically, but they know that the microaggressions that people receive throughout the year, throughout all the years from racism, actually affects your DNA and affects your outcomes.
Yes, yeah.
And that infuriates me that more healthcare people don't know that. So if we can quantify that, and they're starting to do a lot of research, we can maybe make a difference. But we've got to. If we have money available, we've got to use it well. We need to reevaluate. We need to look at what data we have. We need to collect it. That's the other thing. I know in Medicare, home care, we have the OASIS, which is like, if you're a nurse, it's horrendous. It's literally 100 computer pages. It's a lot of work, but somewhere that data is being analyzed about people's health. I don't know that we're doing that in terms of women and babies. I don't know how standardized that is, and I'm
So
not
I can
looking
speak
for more
to that.
paperwork.
Yeah, I can speak to that. The state is working on a maternal mortality and morbidity strategic plan, but it speaks to the establishment of this maternal care quality collaborative, and that is really a data center. There's going to be a maternal data center, which will be a part of it, which will begin to track all of this information by hospital. And so, not for public consumption initially, but to really feed back to the hospital so that you really are aware of what your practices are and what your outcomes look like. This is tied into the Perinatal Quality Collaborative, a lot of acronyms, so forgive me, but that is where we work with the bundles. We work with the AIM bundles and the initiatives and the standardized protocols and training and all of that. So this is a big part of what Governor Murphy and First Lady Murphy are doing, really spearheaded by the Department of Health, because you're absolutely right. We need to establish the baseline, set the targets, and really begin to track folks on that. I know there's also legislation that is talking about not paying people for unnecessary C-sections. When you hit people in their pocket, they pay attention. And so I say that to say we're really in a transitional period where we're really looking much more closely at the things that we are paying for and really looking at the trends over time. I will also say, to Rancha's point, thank you for saying that. We need to hear from the community. You can't make a decision in an office behind a desk, not knowing about what your target population and what your constituents care about, think about, and need. And so I will say, with Healthy Women, Healthy Families, there was this rush to revitalize and retool our initiatives. And we said stop at the direction of our commissioner. And we did focus groups with community folks. Before we decided if we're going to do a doula or we're doing group prenatal care, whatever we're doing, we said we're not doing anything. We're going to speak to the people. We went statewide, north, central, south. It took a long time. It was last January. We decided to do this in the middle of blizzard. So we had every community forum canceled and rescheduled. It took us a while. It was tough. But we really thought it was important to hear from people themselves. Community health workers, moms, people out there in the world trying to hustle and survive. What did we hear? Implicit bias, they don't feel respected when they go to your institutions. They are troubled with mental health issues and the ability to really articulate. They don't even know about all the services. I talked about all these acronyms. They're like, what's that? Who's that? They talked about social supports. Just what you said. There's not the mother or the grandmother. Nobody's helping me when I get home from the hospital. I get home from the hospital with a C-section. I live on the 3rd floor and I have 4 other kids. So how can I survive? And nobody's checking on me. They threw me a nice baby shower before I had the baby. But now that the baby is here, nobody's calling me. I need my laundry done, I need a good meal, I need a nap, and I need somebody to take care of these knuckleheads so that I can focus on the latest addition to the clan. And so those were the real stories we were hearing from people, and based on that information, we then said, what does the evidence tell us that works in these communities, that provides those social supports and will get moms to where they ideally want to be? This is how we decided to invest in doulas. This is how we decided to invest in group prenatal care. We didn't just wait for these things to fall from the sky. They were informed by the constituents, by the people that we were able to mobilize and hear from. And based on what they told us, this is what we did. So this is why it's called a pilot. You know, this is why the things that we've chosen are very intentional. We're doing them in 8 cities, driven by the data: Atlantic City, East Orange, Irvington, Patterson, Trenton, Camden, and I always forget, there's 2 more, but Newark and New Brunswick. High need cities, high need cities. Not by any means exhaustive of where the needs are in New Jersey, but we've started there. Now with this Medicaid reimbursement, we can go statewide. You know, we will train doulas in other parts of the city, and we'll rely on the NAACP and their county chapters to really help us get the word out about these folks.
And I just want to add, I'm sorry, I know you're next. I just want to add on that. What happened was with the Department of Health, the thing I love about the most is that they did go into they wanted to get people who were already doing the work in the community, and I think that just makes such a large difference when you really go and get those groups that are really doing the work already, and you don't feel like it's a kind of like someone who looks like what you want but are not really connected to the community. That's we call it's kind of like having a paid group of doulas to just say, oh, we're already doing it. We really want people who are really on the ground who would, if I walk in my community, we might have been in the laundromat last night talking about what was going on Housewives of Hollywood, you know, having that conversation. But again, that's the kind of energy you want to build in your community, because that's what builds that trust. So I just wanted to lay that with you too. So I appreciate the part of that. Yes, sir.
So I just want to say I appreciate the honest conversation that we've been having all day and calling things as they are. I just want to continue on in that vein. We live in a white male-dominated world, white male-dominated industries. In order to get anything moved, we have to break through that ceiling. And I'm always curious to see when we think about solutions. Everything we spoke about today is 100% needed. Everything we spoke about. And I love the different collaborations that's going to come from this meeting, because I'm the statewide communications chair. My job is to communicate NAACP, but I want to make sure I'm communicating what you guys are doing as well. But as we speak about this white male, not to be specific, white male dominated food sidebar. All the white women in the room keep voting for these same white dudes. Come on, we gotta stop.
Thank you.
But as we speak about...
No generalizations here now.
Hey, listen, just track the polls. So there is base.
There's exceptions to
that. So with that being said, as you spoke about how with your organization, the white women who taught you had to take a step back. My question is, I get that approach, but a lot of these white dudes can't hear you. So we need more white women who are advocates and allies. So what are our plans to get, and we have a large room full of white women, how do we get more white women to take on this issue? Because anytime it's an issue regarding women, they call us. But when it's an issue about black women, we have to find them. Not excluding ladies in the room.
Of course.
But the majority of the women want to enlist black women when it's good for women, but leave black women in the cold. So how do we get more white allies, advocates, whatever term we want to use, on these issues? So the white men who have the money and the power and the resources can put these things to the forefront. Because anyone who say, like, everything in this country right now is about life, How can we keep talking about how much we enjoy life when we're not protecting black women who are losing their lives?
So I'll start with it first, and if everyone doesn't mind this room, I'm going to shift my hat a little bit and put on my community organizer's hat and national organizer's hat. A lot of the work I do is based around public education. Camden, New Jersey is in a public education crisis, right? If you haven't followed the news, and I'm going to say some things here that needs to be heard and said. Camden School District, #1, pulverized by charterization. the Camden students are not failing, they've been failed. The community is shifted because you have 77,000 people in a city. You had 26 schools, and now 9 of them are under a corporate charter takeover, right? But with that, there's a new, the current superintendent has currently just said that we're in a $27 million deficit, and we don't know where the deficit came from. So that in order to save those schools, they want to shut down more schools and fire more teachers. This is always the answer in Black communities, right? What has happened in Camden, and this is what I'm using the story to kind of open up to where what you said. You had made an amazing question. I want to answer that. What has happened in Camden is that we decided to de-silo the way that we organize. So when you de-silo, you have to build two things. You have to build power and lift up the Black voice of the experience, but you also have to kind of integrate a multiracial fight. And in that integration, when we're building up the Black voice so we wouldn't shrink, we called on our white allies. And we said, clear, let's just use education as an example. Why is it that in Cherry Hill there's no charter schools? Why is it that in Morristown there's no charter schools? Why is it that public education is valued and you have old schools like we have old schools? You have alumni, you have old buildings that are in some of these communities in Camden, and no one's screaming, let's go charter and bring in charter schools and bring in a new idea of what progressive education looks like. Because it doesn't require 30,000 Black angry moms in Camden. It requires 4 white women with carriages to say, hell no, this is not happening in my city. Because my child will go to the same school that his grandfather went to, and it's a public school, right? It requires that. So what happens when you meet a group of progressive white women that are organized against Cherry Hill, Voorhees, they're called the Progressive Women, South Jersey Progressive Women for Change. This is a group that's organizing right now. These women have made a mark in Camden, showing you how it's happening. Made a mark in South Jersey to say we will not allow racial injustice and racial inequity to happen anymore while we have an opportunity to vote. So they took on the head. Everyone doesn't want to say this side of space. There's a political boss in South Jersey named George Norcross. They said we're going for the head. They said we're going to make sure that in everything that happens in Camden and anywhere in South Jersey, we're clearly stating the fact that this person has been using his bias, his racism, and his tactics of money to get Camden under his total control. So what's happening? We, Camden organizers, created a group called Camden We Choose. It consists of all African American grassroots organizations, but we also have included our white brothers and sisters. So when we stand and fight about education in Camden, I don't have to say at a board meeting over in Cherry Hill, this is not happening because this white woman is standing right here with me saying, and I live in Cherry Hill, and it's not happening. And I want to know why it's happening here. And how the hell do you run these board meetings like this? I'm going to write a letter. I'm going to call the governor. I'm going to do this. I love the way that white women organize, because they are clear on, I'm going to call the governor, I'm going to call who's in charge, I'm going to use my privilege to do what I need to do. That's the same way it's happening voting right now. White women are standing up, and I hope that I'm saying this in love as a family. They're standing up and using their voice. No more will we be squashed, be settled under a white man's world and say that we don't have power to say we need to say to support women across the board. Why are women suffering? And we have an ability to use our voice and our power to make sure that all of us receive the same exact thing. And in the middle of there's some mucky water, because it does come with us having to kind of like check on privileges and make sure that we're clear on don't cross that line, but it is a growth happening. And I want to be honest about that. I'm talking about real time happening right now. If you look back at the Economic Development Authority, I'm pretty sure if everyone's reading the paper, this is funky in Camden. Governor Murphy is doing an amazing job. At least we won't have to have a sidebar in a second about what's going on in Camden's on the tax incentives that's been given out to all of George Norcross's cronies. Y'all be keeping up on this?
Yes.
So all millions of dollars money has to just given away. Like you get a building, you get a building, you get a building, but it doesn't come back to its residents, right? We suffer. Time is coming. So the point I'm making is that with that happening, if you look at the EDA last meeting, Sue Altman, who's in leadership of Working Families of New Jersey, took over the space at the board meeting, and as a white woman said, we're going to have all the community speak. In that room was people from all over New Jersey. Sue used her ability to say, I have the mic, so I want to make sure that Camden voice is heard because we're talking about Camden, and she gave space to the people from Camden to speak. And when that shifted, and it happened in that space, it changed the entire room. Because now we don't have just people feeling sorry for Camden, we have the people who are directly impacted speaking. So I just want to say to your point, that it starts with us de-siloing and creating coalitions where we can come together on one thing that we know we can win. The small victories is how we build it. And when we're doing that de-siloing and creating multiracial coalitions, that's how we get to build what you're asking for. But we have to all be willing to stand. What are you willing to sacrifice in your comfort to make sure that other races, especially black races, will be able to come up to? Time card?
Yeah, but I just really like your summation. And I think that maybe this might be a good point to end, actually. And, I just really want to, absolutely thank this, fabulous panel. We want to thank you, you're absolutely fabulous audience. And one thing that you could do, is that a lot of people think of the NAACP, they think of it, that's a black organization. Mm-hmm. But I don't know if people know back to the original origins of the NAACP. It actually was started as an integrated organization. And so if you feel that you would like to see more things in this community, or you feel that this was value to you, consider becoming, a member, actually, of the NAACP. So we thank you again, and we certainly thank the Burlington chapter for putting together this event.
I think we accomplished our mission. Yeah. We're going to go out armed with more than what you came in with. Thank you so much to this dynamic panel of women and Dr. Shaw. Thank you to our audience. Thank you to Virtua, Pam Gallis. We couldn't do it without you. Citizens Media, Marcus Sibley, our communications chair, certainly the president of the Southern Burlington County. This is my daughter, I can't call her. Burlington County NAACP. And know that today made a big difference. It made a difference, I think, for a lot of people. Dr. Shaw, I'm a big fan of his because that's my grandchild. I had a new grandchild on the 4th. Why is that important?
Congratulations.
Within 22 hours, we had 7 nurses. Wow. Mom was there. That would be me. Through all of the nurses. And we had many conversations. We had the best nurse at the end. And when I stayed down, she was in D.C., her hand started to swell, and I'm like, well, you don't really need to call the doctor. You're going to do that. And the doctor, they called back, and I heard the whole conversation. And I was satisfied. And she said, of course, if you want to see him, I'll be in the office on Friday if you want to see him. So we went together. So because we went together, I was able to come up here and be a part of this. Because if she hadn't gone to see the doctor, I wouldn't be up here today because I'm her daughter. And we have to advocate for our children. And I have 2 daughters, and now I have 2 granddaughters to worry about. And so it is everybody's issue because they are tomorrow.
They are tomorrow.
And so what we've done here today, I think everybody in this room needs to be applauded. And I appreciate each and every one of you. Thank you. Well, I'd like to thank my doula. If you ask anybody, if you ever hear my mom talk about my pregnancy, you don't know who carried my daughter. She carried her. It was tough watching you go through this. And I don't know, she got from Atlantic City to Virtual Voorhees before my fiance could get here. And so, thank you to my doula. As you can see, this is a family business. Advocacy is in our blood. Being strong women is in our blood. It's generational. And what we want to do is continue to build strong women around Burlington County, Camden County, Mercer County, across the state of New Jersey. I want to thank this panel. I mean, you guys brought it. Like, you definitely brought it. Because we have to.
You can't have a sexy conversation to get business done.
That's right.
Sexy falls under recreation for most, right? And so you can't have this sexy conversation and expect to see real change, okay? And I think that everybody in here is going to walk out empowered. I think we have a whole new group, a new crop of activists and advocates. This conversation is not over. I will say to be continued. Let's work together to build and save lives. Thank you for taking the time on the first real spring day of the year. And still coming. Listen, like I said, this is about all of us. If we weren't for mothers, there wouldn't be children. If there weren't children, there'd be no future. No one can be overlooked. Before I close, I definitely want to acknowledge that we have another NAACP president in the room. That would be Mr. Kevin Barfield from Camden County.
To close out, I appreciate strong representative here, Ms. Dickinson. Again, just to piggyback on what she just said in reference to the help of the coalition that's helping us accomplish things in Camden. It definitely takes all of us. And I can appreciate that. I'm sorry I missed it because, you know, the prior events, but I'm glad I'm here, and we definitely want to take this back to our community. Definitely, our local chapter will definitely be supporting this initiative. And I look forward to meeting y'all again in the future.
Thank you.
Just a couple other quick things. Before we close, I'll let Susan give a quick announcement about a very important event that I was going to make for her, but my flyer has moved.
Thanks.
So please stand and make it.
Thank you. I'm so honored to be able to announce that, as all of you know, of course, 1963, you're all aware of the church bombing that killed poor little girls.
Yep.
And as some of you may know, there was a fifth little girl who survived. Sarah Collins Rudolph, and we're so humbled that she's coming to Atlantic County on Monday, May 28th. She'll be speaking at Mount Zion Baptist Church at 6 o'clock, and being sponsored by the NAACP mainland and Atlantic City chapters, as well as the African American History Museum in Atlantic City, and the Anti-Defamation League of South Jersey. So we really hope you'll get the word out, and there are flyers on the back as well. If you come to my Facebook page or it's free. No. Thank you so much. We hope to see you all there.
Is it the 27th or the 28th?
Tuesday the 28th.
Tuesday the 28th.
Sorry.
You said Monday.
Oh,
okay,
sorry.
so Tuesday.
Tuesday. Thank you.
Tuesday, okay.
6 o'clock. Thank you.
Got you. Thank you.
All right, so we're prepared to close out. Again, thank you, Pam. Pam is like my new best bud. Here we talk off hours during, hey, you know what's going on? Let's check in on this. And that's important because, like I said in my opening statement, Pam definitely showed a vested interest in this program. Not, what do you want to do? Let's see how you can use our space. And, you know, there was a concern, there was a heart for why we're here today. And so I know that I can say with great confidence, between working with Pam and the care I actually received through Virtua and Dr. Shah, and even I attend the women's primary care here, we will be doing more of this. So this is just scratching the surface, and thanks to Rancha, we really got a little deeper than surface. And thanks to everybody. But Rancha wanted to get in the weeds, so anyway, I said to say, you know, we'd love for anybody in here to become a member. We have membership applications in the back. We are also, this is a shameless thing, but it's a proud thing to say. In 2018, Southern Burlington County was your branch of the year for the state of New Jersey. So, memberships are in the back, and we look forward to having everybody.
And I said one thing. So, Krista, you told us, even though you were quite, that you had, a great birth story. So, I want you to tell us, what's the best delivery that you attended? We need to close out on a good birth story.
Yes.
Best delivery. I did a home birth. I have to tell the story. So, Jody, I'm not going to run. So I did a home birth, and It was one of my husband's a school teacher, and it was one of his students who now, moved on, and she's she's in the medical field, and she told me when she was younger, Ms. Rasha, when I have a baby, you're going to be my doula. And I'm like, sure, we got plenty of time. And she called, she said, it's happening. So she said, but I want to have a home birth. And I was like, okay, my first experience. All my experience has been in the hospital. I want to say that my client base is multiracial. So African-American woman at home, young mother had this home birth, and she had a midwife. This midwife was amazing. Asasia Muhammad from Philadelphia, the people's midwife, she's amazing. So we were at her home. Her husband was there. There was music playing all over the house, jazz, and they had their own vibe. And she was just completely, in her natural element. Had a pool in one room, and she was between pool and room, and doing her own thing. And we got there to the point where she was at that edge, the edge is 7, 8. I want to give up. I can't take it no more. And it was hours, it was nighttime. Then it was hello, son. That's how we are. That's the doula's always saying, I'm greeting the sun. I know the sun is coming soon. So she got to the pool, and we were steady going back and forth. Okay, how are you feeling? Her temperament was up and down. She was like, I can't. She was resting in between, and we finally got to the pool. Oh my gosh. And it was my first pool birth, and I'm standing, imagine the pool being a circle. It's warm water inside the pool. Her husband is near her on the side. All the midwife staff is inside there, and I'm the doula in front of her. So the vision is she's on all fours, and you can see clearly in the water the baby's head. And she's like, I don't know if I can do it. And the water was soothing her, and we had, it was just a very natural birth. And she looked at me, and she looked at her husband, and she said, I gotta poop. We said, here it comes. Baby head came down, and in the water, you're looking at it, and you're like, is that the head, or is that something else? Baby head shot down. She did her final pushes on all fours, and baby came out, and it was like a big vacuum of life. And they had it where no one could speak until they wanted baby to hear only mom and dad's voice first. Oh, priceless. I know I'm getting the chills telling the story again. And dad and mom said, welcome to the world, baby. Music played after that. I'm not making this up. And I was through tears, just flowing snot. It was the most beautiful experience I had ever encountered for a birth and a birthing experience. And at home, she just captured that moment, and everything that she wanted and needed and was necessary was there. Her mom was in the room, her mother-in-law was in the room, her husband was there, her midwife, I was there. And I always say as a doula, we are chosen by the Creator, by God, to be in that space, because that's not given to everybody. That's not something you can just say, oh, I'm going to a birth. No, that's not your doulas that is a spiritual space. So when baby was delivered, straight skin to mom, it was just amazing. And then baby is amazingly huge now. Healthy little boy, he is amazing. And every time you have a birth with a mother, you have a birthday, a new child you have a birthday with. So I get, it's so-and-so's birthday, you get those conversations, but that was the most beautiful experience I think I've ever had. And I think that was the shift for me, honestly, when I said that women deserve to have this experience. That was my shift. There was that right there when I said, if I saw something that beautiful at home, how can we capture that in a hospital? How can, everyone may not be able to have a natural birth in a pool, but how can we capture that moment where mom feels as though, I've got this in that space? And that's my beautiful birth story. Oh my gosh.
Well, thank you again, citizen media, because, thanks to you, people were able to partake in this who weren't able to be with us today. And I'm sure they probably enjoyed every minute just as we did. So with that being said, thank you. Thank you to our moderator, Dr. Banks. Again, panelists, thank you for, like I said, there was never a second guess when we made the ask. So thank you again, and we hope to see you all in the very near future. Enjoy this Saturday. Thank you.
Thank you very much.
The state council was going to be so great, just curious though, because I know the work they do a great job on how to organize and see the duties that they do.